Hello, my friends. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I'm also the National IC Support Group leader. It is Sunday afternoon, June 4th, and it is time for another IC Support Group meeting, a live stream. My purpose in doing these meetings is to educate you, to empower you, to give you better resources to use with your doctors, help you improve how you talk with your doctors, ask more informed questions, all that sort of good stuff. Now I bring to you a bunch of college degrees. I've got degrees in chemistry, biochemistry, pharmacology, and I have a master's degree in psychology. And I've been doing this for 30 years, worked with allocating money for IC research, worked with the US Army, all sorts of things like that. So anyway, my goal here is to give you the most accurate and correct information I can give you. And on a day like today, it is super, super important because I have really difficult news to share about one of our IC therapies. And so if you could do me a favor and cross-post this over to your support groups, I would really, really appreciate that because we have got to get this information out. It's devastating new information, potentially about Elmiron. So you may remember that years ago, 4 or 5 years ago, hi Sue, hi Gay, I'm doing okay. I'm bit by mosquitoes. I got massacred by mosquitoes last night. So I've got a bite here. I've got a bite here. I've got a bite on my back. I've got mosquito bites everywhere. I hate being bitten by bugs. But anyway, so I want to take you back in time. 4 or 5 years ago, I had the unfortunate job of sharing with you that the only approved oral medication for IC Elmiron was linked potentially to or associated with retinal disease. And that was a very hard news for me to share. It was hard news because I knew it would change the lives of thousands of patients. It was hard because, hi Jody, other IC experts were not talking about this. I'm the first to talk about it. And ultimately, in the end, I think it's very important that you have full information, that you need to be able to understand the risks versus benefits of medications that you're considering, right? Okay, I can see the mosquito bite on my forehead. So annoying. That's so annoying. Okay. So anyway, we launched a survey that day. Our survey now has over 2,000 patients in it, of whom a significant proportion report retinal disease. And we know how that progressed. We know that the research first came from the Emory Eye Center. Hi, Kayleen. Hi, Sylviane. With a case series. And then we had clinics and researchers from around the world who slowly published their own research, which supported the eye disease issue with pentosan polysulfate, aka Elmiron. We know that the company then issued a black box warning notifying people that there was a significant risk of their eyesight changing, their retinas changing. And we now know that it's in litigation. It's in litigation, that there are a number of lawsuits about this. So I am now in exactly the same position. Because last month, I could not believe it. We have another potentially very serious adverse event associated with Elmiron use, aka pentosan polysulfate. This is an association. They haven't proven it yet, but the data is pretty strong. And they're in the process of developing more data. So it was the eye researchers at the Emory Eye Institute in Atlanta who noticed that a lot of the patients that they were working with retinal disease also had inflammatory bowel disease. and or what we call dysplasia. That means that the cells change significantly inside of the bowel, and they become cells that develop dysplasia are actually significantly associated with cancer. And so it's the Emory eye doctors who were like, well, this is really strange. Why do so many patients with interstitial cystitis, but also taking Elmiron, appear to have quite severe bowel disease? Now, here's the thing about Elmiron. If you go back and you look at the early study, Elmiron is well known to cause gut issues. A number of patients who tried Elmiron developed stomach issues, bowel issues, or rectal hemorrhaging. And, generally the advice was, okay, if you have that side effect, stop the meds. And when you stop the medication, it usually went away. So this is not new per se. What's new is that I don't think anybody really thought about what was actually happening in the bowel in these patients who had pretty significant gut distress with Elmiron. I can remember years ago, I was working with a man who had taken Elmiron for a year. And I think he called me on the phone and then suddenly developed very severe hemorrhaging, rectal hemorrhaging that was associated with the Elmiron use. So, kind of like this is kind of one of those examples where, yes, we know medication can cause side effects, but do we really understand physiologically what's happening in those patients? So we now have the first published case series of 10 patients that shows what they consider a strong association with Elmiron use. Now, some patients have had to have their bowels removed. Okay, that's how serious that is. Sue said, I had severe IBS, so I stopped the medication off and then finally just stopped taking it as it was during. Okay, do I hear that? Definitely. So what I did is I went back in time yesterday and I pulled, there are only 5 published articles on this right now. So the first one was in 2005. Okay, pentosan polysulfate drug-induced colitis. Okay, and this is 2 patients. So I'm just gonna read it to you because I'm going to be really accurate here. So pentosan polysulfate Elmiron is used in the treatment of IC, a clinical syndrome characterized by urinary frequency, urgency, and pelvic pain. Pentosan polysulfate is a heparin drug that has structural similarities to glycosaminoglycans, which prevent irritation of the urothelium. Animal studies in rats and mice have found rectal histiocytic, cellular infiltration, chronic active inflammation, and ulcers with prolonged pentosan use. One dose finding study in patients with advanced malignancy found proctitis in 1/3 of the patients treated with pentosan polysulfate, and that's actually rectal. Proctitis is not prostatitis. It relates to the rectum. So this is 2 patients who had issues. A 29-year-old female developed bloody diarrhea and crampy abdominal pain 1 month after starting pentosan. A flexible sigmoidoscopy revealed ulcers, friable colonic mucosa with punctuate hemorrhage and exudate. Treatment with the normal medications failed to result in improvement. Colonoscopy revealed colitis extending from the rectum to the transverse colon. Mucosal biopsies revealed active colitis with patchy involvement with ulceration. Okay, pentosan was discontinued with a full resolution of the symptoms within 2 weeks. A repeat endoscopy revealed a resolution of the colitis. So she had colitis, she stopped the Elmiron, it went away. Thank you, Michelle. Case number 2, 59-year-old female with a history of IBS developed increased diarrhea and lower left quadrant abdominal pain 2 weeks after starting pentosan. Very similar to the other. Changes consistent with colitis. Typical medications, mesalamine and prednisone did not work. However, the abdominal pain and the diarrhea improved upon the discontinuation of the Elmiron pentosan. Okay, so that's the first publication ever about this. That was in 2005. Now we come to 2015, and this is Elmiron-induced colitis, a rare complication. This was done at the University of Missouri and UC Irvine. The writing is really small. A 32-year-old female with a past medical history of interstitial cystitis presented for evaluation of chronic diarrhea for 7 months. She described loose and bloody stools with approximately 20 bowel movements per 24 hours with nocturnal symptoms. This was associated with abdominal cramps that varied in severity over time. Apart from Elmiron and mirabegron for her urinary problem and pregabalin for fibromyalgia, she took no other meds. Physical exam was unremarkable except for mild abdominal tenderness. They looked for Clostridium. It was negative. They did an initial colonoscopy, which showed what they call mucosal vasculosity and scarring compatible with inflammation. Biopsy showed inactive chronic colitis. Over the following year, she was treated with several remedies for that with no significant improvement. Elmiron was discontinued and her symptoms resolved over a subsequent few weeks. Okay, so that was in 2015. There's another one in 2015. Elmiron-induced hepatotoxicity, and actually this is about the liver. So we don't really need to go into this one. 32-year-old female with past medical history of IC, chronic joint pain, and thrombocytopenia, presented for evaluation of abnormal liver test. She had been placed on Elmiron for a urinary symptom. She had no jaundice or skin rash. Physical exam was unremarkable. And again, let me just fast forward here. The abnormal liver tests were attributed to a drug-induced liver injury, and Elmiron was discontinued. Liver enzyme showed a nice trend downward and eventually resolved. And we've known that. We've known that Elmiron can change liver enzyme levels. We never really want to mess with the liver that much, right? Now we come to 2022, last year. You need to see how small this writing is. This writing is really small. Pentosan, so let me just read this because it's real short. So pentosan polysulfate is used for management of IC. At one institution, we incidentally noted 6 patients who were on this agent who had a diagnosis of inflammatory bowel disease. 3 of these patients stopped the drug, and all 3 had a clinical and/or endoscopic improvement. 3 of the 6 patients developed multifocal dysplasia. This observation led us to evaluate the hypothesis that pentosan polysulfate is associated with dysplasia in patients with IBD. They found 30 patients who met their search criteria. Of these 10, 33% had colonic dysplasia with low-grade dysplasia. With low and high-grade dysplasia. Of the patients with dysplasia, 6 required a colectomy for endoscopically unresectable dysplasia. Following physician consultation, 3 patients discontinued the drug and subsequently demonstrated clinical benefit and achieved an endoscopic healing. Their conclusion: inflammatory bowel disease at 2 institutions who had taken pentosan polysulfate had high rates of colonic dysplasia leading to surgery. Patients in this cohort who stopped this agent showed improvement in their colitis. These findings raise questions about whether pentosan polysulfate may play a causal role in both the development of colitis and the observed high rate of dysplasia. If larger studies validate these findings, this would indicate a readily identifiable subset of patients who are at high risk of developing colitis-associated malignancy. That when cells change shape and the tissue changes shape and becomes develops dysplasia, that's where we see cancers beginning. Do you get what I'm saying here? How important this is? Okay. And now we come to the case series that was published a couple weeks ago. This was a retrospective case series performed at 2 tertiary care centers at Oregon Health and Science and Stanford Healthcare. We identified 30 patients with inflammatory bowel disease who had past or current use of pentosan polysulfate for at least 2 years. Oh, wait, that's the abstract for this one. Yeah, it is. Okay. Okay, so I already read that. And now we have yet another one. And this one is in pre-press, so it hasn't been peer-reviewed yet. And this comes from Emory. So remember, these guys at the Emory Eye Center, it's ophthalmologists that are leading the charge here. It's ophthalmologists that are being the heroes. And they're the ones who found the correlation with Elmiron and inflammatory bowel disease, potentially. So in this study, they had, let's see, in a cohort study of individuals with a history of prior long-term pentosan use, case histories were obtained, and GI disease course was followed with review of their endoscopy records and histopathology, and they summarized the findings. The strength of the association between pentosan use, the diagnosis of IBD and or irritable bowel system was measured. They found a strong association between pentosan use and a clinical diagnosis of inflammatory bowel disease. So in this cohort study of 13 patients, the median pentosan exposure was 2.04 kilograms. 11 patients developed symptoms suggestive of inflammatory bowel disease or IBS after beginning Elmiron therapy or pentosan therapy. Of the 10 participants whose findings were reviewed, 6 had abnormal appearing colonic mucosa on endoscopy, and all 10 had abnormal mucosal changes on histology. Clinical and histological improvement was observed after they stopped the medication. So they say in this cross-sectional study of 219 subjects with IC, pentosan use was statistically significant. It was a statistically significant predictor of both inflammatory bowel disease and the composite IBD-IBS. And it's a very long study. I studied it yesterday. There are some pictures. Jody says, I took Elmiron in 2011 for 3 months only and started having IBS symptoms, and they've never gone away. Thank you, Danielle. Danielle, we're talking right now about a pretty severe adverse event associated with Elmiron. Let me see if I can get to these pictures. They do say it is unclear whether it's the pentosan polysulfate itself or a metabolite that is associated with retinal and gastrointestinal diseases. So the Emory, the Emory researchers are spot on. Let me tell you, they go back to the beginning. So in this paper, let's see here. Current FDA labeling of the drug includes GI-related findings from an unblinded trial of 2,499 IC patients treated with pentosan for varying duration. Colitis is mentioned as one of 38 adverse events with a frequency of less than 1%. The label cautions that patients with gastrointestinal ulcerations, polyps, or diverticulitis should be carefully evaluated prior to the use of Elmiron. Other studies have reported adverse GI effects with pentosan users. A phase 1 study investigating pentosan for advanced cancer, 20 to 21 subjects experienced grade 1 or 2 GI bleeding. Another study found that 4% of subjects receiving pentosan 300 milligrams per day for 32 weeks experienced retinal hemorrhages. And finally, the Anderson retrospective case series demonstrated high rates of colonic dysplasia among inflammatory bowel disease patients who took pentosan. Notably, a majority of these cases, let's see, hold on. Our study is suggestive of a novel association between pentosan and colopathy. These findings have important public health implications, given that pentosan has been widely prescribed for decades. Although this may be a reversible condition, there is a significant burden of disease that often prompts invasive diagnostic tests and treatments. Colonic dysplasia in some patients suggests more deleterious outcomes are possible. Further study is warranted to investigate a potential causal relationship, evaluate the clinical impact of this condition, and explore the pathobiology of the disease. I highlighted so much. I'll be doing an article on this. I just want to talk to a few more researchers. I wanted to see. So, one of the theories as to why this could be happening goes back to research, and that how do we research, quote unquote, IC? How do we research, quote unquote, a bowel disease like irritable bowel syndrome? Well, often what they do, and you guys hold your questions, I'll get there. Hold your questions. One of the ways that they mimic IC is they put a medication called dextran sulfate into the bladder. And this dextran sulfate damages the bladder wall. Well, it turns out that the chemical structure of Elmiron is very similar to the chemical structure of dextran sulfate. And so there is a suggestion that that would be the similarity. And then we have some of the first pictures ever. So this top picture is chronic mucosal injury characterized by crypt dropout. Means that basically the skin is collapsing, the architecture is failing, and there's some thickening. So that's this picture right here, right? You can just see that the skin is now very unorganized, or this tissue, and this area right here, that's thickening, that shouldn't be there. And then B is injured colonic mucosa showing architectural distortion and inflammation, and that the inflammation is progressing from left to right. And so this is very, very inflamed tissue right here, and the inflammation is spreading this way. Anyway, so we have got to let patients know, for those who have been using pentosan, and there are some patients still using it even after the eye disease issue, that if you are having any bowel issues at all, You must talk to your doctor about this new research, because the worst case scenario is that the inflammation that the medication could be causing will lead to dysplasia, which could lead to cancer. That's the concern. I find myself, kind of kicking myself in a way, because it's like we accept the discussion of side effects. The doctor will say, yeah, if you have stomach upset, if you have rectal bleeding, stop it. But it's like, why is the side effect happening in the first place? And is it causing damage? And is it causing long-term damage? Could it cause other bad things to happen? So we have now opened up another giant can of worms associated with Elmiron. Just like we did with pigmentary maculopathy, we will be sending out a survey. I don't know if it's going to be my survey or if one of the researchers will want to do a survey to our 30,000 plus members. So I will be sending out an email about that when that happens. Mary says, side effects with everything, you must weigh your pain in some patients who are suicidal. I understand that. I believe me, I understand that. So let me go back and look at some of your questions now. So I think the most important part of my job as an IC activist is to have hard discussions like this, based on research. This isn't me making this up. This isn't somebody on the internet trying to get you upset. These are multiple researchers from across the country who have found this association, emphasis on association. They haven't proved that that's what's happening, but they have developed strong data supporting a strong association. Okay, so it's alarming. I find it quite alarming. Anna says, can you repeat the name of the estrogen cream, and please with no parabens? Just estradiol. Just an estradiol cream. Sue, I don't understand what you said there about trial period. Michelle says, want to let you know I'm thinking. Thank you, honey. It's been a bit of a better week. We got to the mortuary. We created all of our plans, paid a lot of money. Who knew it would be so expensive? And our graveside service will be in the next 2 weeks. I'm not giving specific information. You're not supposed to give specific information because people come in and rob homes during funerals. So Sue said, my IBS at that time was so severe I could not leave the house, but never made the connection with Elmiron until you mentioned it. Exactly. Anne says the flowers are beautiful. You know where these flowers came from? My dentist. I called my dentist to change an appointment, and that's so nice. It's just so incredibly nice when I told them that my parents had died. All right, hold on a second. Lori says, can you help me with a good probiotic for IC? Thank you. Some seem to flare me. The reason why probiotics flare you is that some people have a histamine reaction to probiotics. And we've always wondered why some patients flared when they took a probiotic, but now we know, and it was actually Gay Sandler who helped us understand what was happening, that it's actually kind of an allergenic reaction. And so number one, Lori, I would look for live cultures. Like I get my probiotics through coconut milk yogurt. Some people drink kefir. I don't know how you can drink kefir and stuff like that. It does not appeal to me at all. So we go for the live cultures ideally first. In terms of brands, Natural Approach to Nutrition has a product called Elflora, and they're working on a brand new one. I don't think it's quite ready yet. That's a company that I think is the most spot on with their product development and research and product quality and pricing. I mean, I'm so impressed with this company. I can't tell you how impressed with this company. They continue to surprise me every week just with their diligence and their communication and their dedication to product quality. I mean, I'll tell you, a lot of companies that have worked with the IC world, you know, you can't get a straight answer out of them. Remember with the whole Cysto Protect cancer warning? All of a sudden our bottles of Cysto Protect had, cancer warning on it. It's gone now. I mean, they fixed the problem, but nobody told anybody about it. And I'm like calling the company going, what's up with the cancer warning? Talk about alarming. I mean, that did tremendous damage. And of course, Far Laboratories, makers of Cystitis, which was a very, very big company early on, 20 years ago, they're going through bankruptcy now. So I am a creditor on that. I have no chance of getting the money that they owe me, probably none. Sylvianne said, I took Elmiron for 17 to 18 years, have retinal problems caused by it, now also have bowel problems as well. This explains everything for me. Exactly, Sylvianne, exactly. So I hope you're not taking it anymore. I mean, what those published case studies show is normally when you stop the medication, the bowel symptoms go away and the bowel heals unless you let it persist so long. Marcia says, do you have any information or knowledge about Salt Lab magnesium oil spray being used on the abdominal area for inflammation? One IC sufferer said it helped her immensely. Never heard of it? Salt Lab magnesium oil spray. Well, you have to remember, number one, we're all very different. We have phenotypes. So her phenotype might not be your phenotype, et cetera, et cetera. So this is designed to restore magnesium levels in your body, lower stress. Holy moly, is that expensive. Lower stress and inflammation, relieve sore muscles and joints, calm your nervous system. Last but not least, facilitate a restful sleep. It relaxes muscles, the muscle relaxant. So pelvic floor, that could potentially help calm some of the pelvic floor, maybe calm a little bit in the nervous system, but we have no direct experience with this at all. None. Six to 8 sprays under your stomach, legs, feet, or back, 10 to 30 minutes before bed. You've never used magnesium oil before, start by using it on your feet for only 2 to 3 weeks to allow your body to adjust. Supposed to do patch tests. What's in it? Just magnesium chloride. Don't know anything about it, but it looks kind of interesting. So guys, I'm not recommending it because I know nothing about it. Bridget said, I've been on Elmiron for 20 years, get my eyes checked. I grew up with GI issues long before starting Elmiron. GI issues haven't worsened in these 20 years. Combination of Elmiron and DMSO and stills put me in remission for much of the last 15 years. Yeah, well, it's not everybody. It's not everybody, but it's important. Yes, Mary, this is absolutely something very new. It was just published last month for the first time. Michelle says, it really annoys me that most urologists will push this to take as your first line treatment because it's an easy way to test you. I found it odd that most don't know the side effects. Yeah. I mean, what I would say, remember, I have a degree in pharmacology, drug development, right? I mean, that was not pharmacy, it was drug development. How do you make drugs? And I think that what we all have to completely understand, respect, is the human body is miraculous. The way the human body works, all the different pathways of neurotransmitters and how muscles work and how the bladder wall works and how the heart works and all this sort of stuff. And it's kind of like humans thinking that we could ever create something as beautiful as a monarch butterfly wing. We will never be able to do that. There's nothing we can make handmade that will look like a monarch butterfly wing. The animal itself is a miracle. And I think that the arrogance in pharmacology is, and in the chemical industry in general, is, I think they cross a lot of ethical lines. I think they do. Especially with like Roundup and things like that, where, I mean, how many research studies do we need to show that what you have created can cause physical harm? Or the fact that a lot of the flea medications and wormers that you give to cattle actually end up killing the vital bacteria and species that we need for our diversity in land, you know? Poop plays an important role in, in fertilizing our land. And it creates, there's food in there for insects and like dung beetles. But if you kill all that, then you're killing the start of the ecosystem. Then you're killing vital insects. So anyway. Yes, coconut milk. Hi, Shlomi. Can you suggest a good PT practitioner on YouTube for IC? You know who I like the most is Pelvic Pain Rehab. And they have a number of videos and they have fantastic blogs. And their website is pelvicpainrehab.com. And they have a number of videos that are quite good. And their educational campaigns on Twitter and through social networking are just phenomenal. I don't know how they have the time to do it, but they do amazing work that I envy because I wish I could do for IC what they do for the pelvic floor. So go over to pelvicpainrehab.com and especially check out their blogs. Their blogs are fantastic, absolutely fantastic. And there are a lot of blogs on men. So it's not just women, it's men also. Okay, hold on a sec. Hi, David. Bruce says, I hope you're doing well. Sending love. I'm doing better. I'm definitely doing better. You know, the shock, I think I'm over the shock. I was just in shock for 2 weeks. And now I'm in the, you know, it's funny. I was going through the grief cycles with a friend yesterday on the phone. And it's like, okay, I'm not pretending it didn't happen. I'm not avoiding it. And I don't hit the grief cycle change. I'm not going to fight it. I mean, I'm not aggressive about it. I'm not angry about it. I'm not. They had good long lives. And it was their time. So I'm sad about it because I miss them very, very much. But I also feel like they're with me all the time. All the time. Thank you, Lori. Thank you. And it's not, you know, like the great thing now is I can actually work again. Like my to-do list, what I want to try to accomplish this summer is massive, this huge new masterclass on IC on video that you can go through at your own pace. It's going to be free. I want it to be free. So I've got it all mapped out on my board. I've already started it, but just I had to stop and start with elder care, you know. I'm also late with my spring IC Optimist magazine, so that's going to be bundled into our summer IC Optimist, and it's going to be a very big issue. So just have to write the articles. I already know what they're going to be. Just have to write them, which I've started. Michelle says, I've been in a chronic flare pain in my bladder and kidney for 2.5 weeks. I'm in Australia and I can't see my urogyno. She has a 2-hour flight home, as she's a 2-hour flight from home. I've been in emergency and got me an injection for the pain, but it's worn off. And you were given Polexia to help. I don't know what Polexia is. I've never heard of that. That might be an Australian med. So, girl, Michelle, what you've got to try to figure out is what kind of flare you're having. Okay, because there are different types of flares. So you can have a bladder wall flare, or you can have a pelvic floor flare, or you could be having a hormone or stress flare. So let's talk about the difference here. If you have pain as your bladder is filled with urine that is relieved by urination, so the fuller you get, the worse you feel. And as soon as you pee, you feel better. That is pointing us to your bladder wall. And so that's when we want to do bladder wall interventions to try to calm the bladder wall down. So what's the first thing that you would do? Number one, try to get more water in you. We've got to dilute your urine. There's something in your urine that's very, very provocative. Now, number two, you might be eating some food that your body's not used to. And when you're traveling, you don't want to drink the water necessarily. So you're going to open up a can of Coke because you think you can trust a can of Coke or a can of 7-Up. So if you've got a vulnerable bladder wall, if you've got estrogen atrophy and your bladder, again, is a little bit more vulnerable, then those foods are going to be irritating. So let's try to identify risk factors, things that you're doing that might be a little bit more provocative. And it might be something that you think is perfectly safe, like a vitamin. Did you take a vitamin with you on your trip? A multivitamin. Multivitamins are very difficult for most bladder wall patients. You can alkalinize your urine. So your next step is to try to make your urine a little bit less acidic by doing something that will alkalinize it. So how do we alkalinize it? We alkalinize it with pre-leaf, which is, most people have seen pre-leaf, right? This is absolutely the most well-known and the most popular supplement ever used by IC patients. It doesn't act on your bladder. It acts to reduce acid levels in your urine from food, right? So this will alkalinize your urine. Or you could suck on some Tums. Tums, calcium, will do exactly the same thing, calcium carbonate. Or you could even, if you could be a little bit more aggressive, but we don't like doing this very much. You could do a little bit of baking soda in a glass of water. Sodium bicarbonate will absolutely alkalinize your urine. The problem with sodium bicarbonate is that it is sodium and it will raise your blood pressure if you have high blood pressure. I am more of a high blood pressure person now, so I would never do that. I'm very, very invested in keeping my blood pressure as low as possible. And it's been pretty good for the last couple of months. So we want to, let's go ahead and alkalinize your urine and see if that helps a little bit. You could do something that will have a soothing effect. So you could try some aloe. But I don't know what kind of aloe is available in Australia. But just as aloe is soothing to sunburns, aloe can be soothing to the bladder, although some people are intolerant to aloe. But like we have in the IC Network shop, Aloe Path, which is very popular for patients struggling with flares. So that would be something that you could potentially go to a health food store and see if they have a really high quality anthraquinone free aloe. That might help a little bit. We don't know. And there's no way to say if you're an aloe intolerant or not unless you try it. It'd be nice to talk to your doctor about it first, see if your doctor liked the idea of you doing something like that. But that's a go-to for some patients. Of course, if you were near a doctor, you could have a rescue installation where they could put some lidocaine in your bladder, a little bit of heparin in your bladder that would immediately soothe your bladder wall. And for the long term, if you are a bladder wall patient, an estrogen atrophy patient, or a chemocystitis patient, doing something that has chondroitin in it, like bladder builder or bladder rest, would maybe give that bladder a little bit more of a coating effect, maybe. So concept number one is a bladder wall flare. Concept number two is a pelvic floor flare. So a pelvic floor flare happens if you've had sex, if you've been exercising, if you've been sitting and driving in a car for a long period of time. And I know it's really strange that you have intense frequency urgency and you're going, that's got to be your bladder. It's got to be your bladder. But we have brand new research that was presented last month that actually has found that some of the highest levels of frequency urgency come from tight muscles. So we ask the question, when is your pain the worst, before you pee or after you're done peeing? If your pain is worse after you're done peeing, that points us very clearly to your pelvic floor. And so for those flares, we need to do things that will relax pelvic floor muscles. So heat, sitting with a heating pad. If you have a wand, right? You can do some internal massage that will help those muscles relax, or physical therapy, or even a muscle relaxant. I will tell you, because I am a pelvic floor patient, whenever I travel, whenever I fly, whenever I drive, as long as I'm not driving, if I'm the passenger, I am always on a skeletal muscle relaxant, Flexeril, to keep my muscles relaxed. I mean, for me to get to San Francisco International Airport, that's a 2-hour bus ride for me. And it's the worst way to start a flare because I always go into pelvic floor spasm on that freaking bus. And I can't tell you the number of times I'd get to the airport and I'd be crying. Now granted, things are a lot better for me now, but I understand the mechanism, the triggering mechanism, and that is just the bouncing in the bus triggering my pelvic floor. So I end up, for the duration of the trip, using a quarter of a Flexeril every 2 hours or something like that. So I always have a little bit of a skeletal muscle relaxant on board until I get to the other end. And then on the way back, I do. I mean, I've flown to London that way. It has worked for me personally. If you're having a hormone flare, as some women do, where you flare the day that you ovulate or a couple of days before your period, you know that that's not a flare to get upset about. That's a flare that, it has an endpoint. Once your estrogen levels normalize, the flare normally stops. Of course, we definitely want to rule out, make sure you don't have a UTI, especially since you're having kidney pain in addition to your bladder pain. So hopefully if you've gone to a clinic, have them done urine culture, or you've gotten a dipstick azo to just make sure that you don't have a double positive leukocyte nitrite. If you have positive nitrite on a dipstick, you have an infection and you're going to need to go to urgent care and get an antibiotic to get you home. But girl, you got there and you can get home. I mean, I made it to London. I made it to London twice when my symptoms were really, really severe. And they're so much better now that I've done proper physical therapy. So much better. Okay, stop me from itching. I have a mosquito bite here, right? I have a mosquito bite there. You can see that's all swollen. I got a mosquito bite here. I hate mosquito bites with a passion. They want me to itch them, and I'm not. They want me to scratch them, and I'm not going to scratch these mosquito bites. Tonight, what I'm going to do, because it's been really cold here in California, but we're finally having couple of warmer days. I'm going to put the fan on facing where I sleep so that the mosquitoes can't fly through it. And I made the mistake of leaving a couple doors open for hours yesterday. That's how they got in the house. Marlia says she's a big fan of magnesium spray. Cool. Nothing is helping. What can you recommend for the pain? I haven't been to You haven't been to work for a week and a half? Excuse my typos. It's early morning here. Okay, so you live there. Okay, you're not visiting. You live there. I mean, it's moments like this when doing a little bit of CBD. CBD oil would be useful. A CBD product, medical marijuana, muscle relaxant, and if available, an opiate medication like Norco. Ultimately, in the end, for those moments when the pain is really out of control, it's usually kind of an opiate moment. Little tiny bit of Norco, quarter of a pill, a half of a pill might stop the flare completely in its tracks. Marlia says she's a big fan of magnesium spray, lotion, and Epsom salts. And magnesium. It has muscle relaxing properties. TheraWorks makes a pump foam that will stop a leg cramp immediately, kind of an old-time remedy. Also a big fan of castor oil packs on the belly. Old remedies that have no side effects, which is always a plus, definitely. It's not the bladder wall. Okay, so it's not the bladder wall. You have a bully narcissist boss. Okay, so you're having a pelvic floor flare, so grab your heat. And, see if your doctor, tell your doctor you don't have pain as your bladder fills with urine, that you have pain afterwards. When you urinate, can you start your stream right away, or do you hesitate 5, 10, 15, 20 seconds before you can release urine? One of the classic symptoms of pelvic floor dysfunction is that you can't start your stream right away. Or you know how you have pee envy if you go into a bathroom and you're sitting on the toilet and you're just dribbling, and then somebody comes in right next to you and they pee like a horse, and you're listening going, how do you pee like that? I've never peed like that. Right? And that's because they have normal muscle tone. But for those of us who have had messed up muscles for a long, long time, getting that nice, thick, full, natural, immediate urination is challenging. Those muscles are tight. You could also potentially ask for baclofen. Baclofen, Baclofen, is a non-sedating skeletal muscle relaxant. And so you could take that at work. You can drive with it. I couldn't take baclofen. It made my face itch. So I was stuck with a Flexeril, which can have a few more sedating properties to it. Hi, Christine. Hi, Debbie. Kayleen says, I'm not ready for the wand. I think it's my fault because I don't know the pressure and the directions. I bleed and it burns everywhere. Yeah, you're not ready, honey. Okay, is that a mosquito? What is that? It just flew across my face. Where did you go? Okay, Chloe said, recently had a cystoscopy. It showed inflammation of the bladder neck and some word was used that basically said, so fibrotic. They said you had a fibrotic bladder or fibrotic tissue. Doc said, that's why I can't fully empty my bladder. You've had extreme frequency for months. You took a microgen test, as all traditional urinalysis came back negative. Microgen came back positive for bacteria. You're on an antibiotic now, and my extreme frequency went away in hours. Yeah, baby, that's what we love to hear. I get sporadic intermittent burning, mostly on my left side above my hip. It recently traveled below my belly button. I can't figure out if it's due to food sensitivities or not, it actually sounds like a nerve hunt. It sounds like your bladder screaming in pain. So what's going to happen? Your muscles are going to get tight to protect you from that pain. That's what happens. And it sounds like you have a muscle that's squeezing a nerve, burning. I mean, you might have a trigger point on the left side. You might have some referred pain on the left side. I'm itchy. You know what? Hold on a sec. I got some CeraVe anti-itch. Hold on. Redhead, sensitive skin. I love this stuff. CeraVe Itch Release Moisturizing Cream. It's wonderful. I got to put it on my... See, here's the thing with central sensitization and having a very sensitive nervous system. Man, if you've got something hurting on your skin somewhere, it's like it sensitizes all your skin. And it's so freaking annoying. Like now, my skin on my arms is just, it's so unhappy with me right now. You've been on the IC diet, had a drink from the Try It and See column yesterday at 3 a.m. You woke up with that burning sensation under your belly button. Huh. What was it that you drank, hon? What was that? But if I'm not fully emptying my bladder, would that make sense while I'm still having the burning? Is this indicative of IC or just sounds like an infection? Well, anytime you have pain on the left or the right side, that's not your bladder. That's something beyond your bladder. But, I call it the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved. They cannot not both be involved because they're so interconnected. And so the ultimate dilemma here is figuring out which came first. So for some of you, this begins with a bladder wall injury like chemotherapy, or you drinking way too much soda or coffee. And of course, your bladder was never designed for the massive levels of acid that we get through fast food. And eventually that acid is going to erode or eat away and erode at the inside of the bladder lining and cause issues. That is the equivalent of a chemical injury. Now your bladder's screaming in pain, your muscles are going to get tight in a guarding reflex to protect your pain. Our therapeutic priority for this patient is to figure out what the irritant is, address the irritant, calm and soothe the bladder, and we're going to hope that the pelvic floor muscles will release out of that guarding reflex. So that's the small group. The far bigger group in the IC patient population is that the foundation for all of our issues actually began with some sort of muscle injury, and it could have been in childhood. So let's say you were fell and broke your tailbone, or you were hit by a car as a kid, or you were a paratrooper and fell on your tailbone too many times, or you were a gymnast or an ice skater or a football player. Okay. Now you have no idea you have anything with your muscles going on, but every time you fall, you injure muscle. And slowly over time, trigger points develop in that tissue, which makes it even more dysfunctional. And eventually, those what we call latent trigger points become active trigger points, and painful trigger points, often after a very, very minor event because of the history of trauma in there. You having a couple of children will do that. Well, of course, your first symptoms are frequency, urgency. So you call the doctor and say, hey, doc, I got an infection. Doctor goes, okay, here's some antibiotics. The antibiotics don't work. You go back to the doc. The doc says, oh, well, let's just try long-term antibiotics. Maybe that'll work. But they don't work. You go back and the doctor goes, hey, I think you've got overactive bladder. They give you overactive bladder meds, but they don't work. And eventually you get I hate to break it to you, I think you've got interstitial cystitis, this incurable bladder disease. Here's a diet, here's some Elmiron, here's an antidepressant, I'll see you in 6 months. And you want to get better, so you do it. You follow the diet. You take the Elmiron. You do everything they tell you to do. for 6 months, a year, 2 years, 5 years, 10 years, 15 years, 20 years, but you're still flaring. Why? Because none of those treatments will fix the underlying problem, because the underlying problem is reduced blood supply from tight muscles. You ever heard the term ischemia? Ischemia. Ischemia. Ischemia happens after an injury where we don't have good blood supply in tissue, and tissue starts to suffer and in some cases die. So if your bladder is supposed to get 24, 28 units of blood a day and it's only getting 10 because your muscles are so freaking tight, are you going to have a healthy bladder wall? And the answer is no, you will not have a healthy bladder wall. Not even close. So our therapeutic priority for these patients is to restore blood supply. And how do we do that? We do that with physical therapy. We have to get these muscles to release and relax. And I'm the perfect example of this. Because my earliest symptoms started in 7th grade after I broke my tailbone. And I was diagnosed with a urethral stricture. Meant my urethra was very, very narrow. I had about 100 urethral dilations, right? And remember, I told you when cleaning out my mom's things, this was the hospital band that she saved from 1973 for me going into the hospital for a cystoscopy. They put me out for it. Okay, 100 urethral dilations. Then I had vulvodynia. My perineum was on fire. And this cascade of things happened, right? But I will tell you, bladder therapies never worked for me. I just continued to get worse and worse and worse. And by the time I was in my 30s, when I first really had severe bladder pain, I did all of the antidepressants. I did the antihistamines. I did the bladder installations. DMSO didn't touch it for me. None of those touched it for me. What healed me completely was pelvic floor physical therapy, combined now with working on calming all those nerves down that all got so messed up because of this long-term muscle problem. I am IC subtype 3 pelvic floor dysfunction, and I am IC subtype 5 central sensitization. The legacy of untreated injuries is nerves get sensitive, and they get sensitive locally where the injury is, and if it's not addressed, they then become regional sensitivity, and then it becomes central sensitization. So I am a central sensitization patient, and I'm a redhead, so my nerves are always going to be much more sensitive. Okay, I swear I just heard something in the house. Hold on, I'll be right back. I gotta look. Nope. It's my neighbor. Okay. So if you, as our guidelines say, as our new updated AUA guidelines say, and it's now been a year since they've been updated, at your very first appointment, to figure out what the hell's wrong with you, they are supposed to do a pelvic floor assessment. And if that pelvic floor comes back tight, that is to be an immediate referral for pelvic floor physical therapy. And pelvic floor physical therapy works far better than bladder therapies. And we knew that in 2008 when the first research study came out that pelvic floor physical therapy outperformed bladder treatments by like 2 to 1. And that was the moment the IC world got turned on its head, because up to that point, everybody's going incurable bladder disease, incurable bladder disease. But then we have a massive research study that showed that Wait, what? Physical therapy helps? How is that possible? It's a bladder disease. Oh, maybe it's not just a bladder disease. Maybe the muscles are part of the problem. And of course, now we know that 85 to 90% of us have muscle problems. So we're a long way now from the incurable bladder disease issue, a long way now. Hold on a sec. Elena, what does a pelvic floor feel like? Flare feel like for me? Okay. So with the stress of my parents dying, I have had 3 wicked pelvic floor flares, but I knew what they were and I stopped them in their tracks. So basically a normal day. And then all of a sudden I felt burning and I had to pee every 5 minutes. And it felt like, so I had to pee every 5 minutes, and I felt a lot of discomfort in my vaginal introitus, which is the entrance to the vagina, around the perineum. And of course, the absolute test for me is just going to the bathroom. If I can't start my stream right away, then I know my muscles are jacked up. I know it. And so each time, I mean, it took like 45 minutes for me to go, oh, you're having a flare. And then I go get my wand and I drop trow and I work for 5 minutes with my wand and I get my muscles out of spasm. And that's kind of a stress reaction. Stress causes muscles to get very, very tight. Mary says, hello, Jill. So appreciate your wisdom. Thank you, Mary. Does it cause vulvar burning? Yes. And it can cause pins and needles on the vulva because if your muscles get so tight, they're going to start squeezing the pudendal nerve, and then you're going to have a lot more vulvodynia symptoms. And for me, the last time it happened to me, it felt like I was being poked by needles in my vulva. And what's interesting about that is the first doctor I saw said it's a yeast infection. He said, you're bright red. It's got to be yeast. Put me on yeast meds, didn't touch it. Then I went a week later to my regular OBGYN. She goes, I think it's eczema. She goes, you're bright red. It's got to be eczema. And she put me on steroids for 6 weeks, and it got progressively worse on steroids, progressively worse. And finally, I talked with the pelvic pain specialist, and she goes, Jill, you don't know what this is? I'm like, no, I have no idea what this pins and needles is. She goes, it's your tight pelvic floor muscles. They're squeezing your nerve. I'm like, I had no idea that it could manifest as pins and needles. I mean, it was just such a weird symptom. It just never dawned on me that my muscles would be the issue. And I swear, my allergies are going crazy, probably from these flowers. That might be why I'm itching a little bit more too. All right. Christine says, I spoke to you about 6 months ago after I had Medtronic device surgery. I was taking vitamin C and immediately stopped. I've come so far thanks to your advice. I'm taking my dad on a cruise. Awesome. Any recommendations to make my travel stress-free? I have a bunch of articles on that on the IC Network website. I think it's important to bring meds with you if you can. So I would, if you have pelvic floor tension, pre-medicate with a little bit of muscle relaxant during the trip, at least to get to the cruise. I would, it depends on how more recently you've had, how long ago you've had pain. If you can get your doctor to maybe give you a little tiny bit of pain medicine, not a lot, like 4 or 5 pills of Norco or something like that, just to have on hand, is not a bad idea. You guys, Norco is a short-acting opiate. It's like Vicodin, only it has less Tylenol in it, and it's only effective for, at the most, 4 hours. This is not a long-term time-release medication. This is just short-term. It's a short-acting pretty easy medication that could reduce some severe pain. Not 50 pills. I'm talking like 4 to 5 pills, maybe. I would be careful with what you're eating or drinking. It's going to be tempting to eat a lot, and you don't know how they're treated that food. I would be a little bit careful of salad bars, because sometimes they spray them with sulfites to try to keep the everything green and preserved. And I've had a few issues with salad bars. I'd keep your spices down a little bit. But most of all, I would just do anything and everything you can do to have fun with your dad. You know what? You can do it. If I can fly to London with very, very, very severe IC, you're doing very, very well. I would go on that trip and enjoy it with abandon, and just, you know what you need to do. Keep your stress low, try to just eat moderately, eat safely, and then just enjoy the memory and enjoy the moment, because you're going to make some really, really good memory. Lauren said, oh my God, I get that totally. My daughter thinks I'm weird because I listen to other people's urine stream. Only we can understand that. Exactly. Chloe says trabeculation. Is that a word that I should have used? So you guys, we're broadcasting live right now. If I'm looking over here, I'm looking at YouTube. If I'm looking here, I'm looking at Facebook. Trabeculation is when something blocks the urethra like a kidney stone. You can slow down or stop urine from getting out. Your bladder walls must work harder as your bladder tries to force the urine out. This can cause the bladder wall to thickening. That thickening of the bladder walls is called trabeculation. See, you learn something new every day. Marlea says, is the PEA also called Pure in the ICN store, and is that the right one you recommend? Yeah, that's the one I take. Palmitoyl ethanolamide, also known as PEA, and the IC research study that was released in 2019 showed that 87% of patients reported a significant reduction in their pain and symptoms by month 3. By month 6, some were completely pain-free. And the general consensus among the researchers with PEA has been around for decades. They've studied it with acute pain, chronic pain, surgical pain, fibromyalgia, burning mouth syndrome, sciatica, etc. The general consensus among the researchers is that it calms nerves down, that it's best for neuropathic pain. And in fact, I did not take it last night. Son of a gun. That's probably one reason why my skin is so weird today. I have to order more myself. Karen says, where do I use my itch cream? Wherever I itch. Lori, thank you so much for the 50 stars. Hey, for anybody out there who's watching this, we really need your support too. I mean, this is free. It's always been free. The IC network is free. But we still have pretty significant bills to pay for internet and for, obviously, 2 separate streams and stuff like that. And the way you can support us is you can just come over to the IC Network store and see if there's anything that you'd like to buy, like our book, IC 101. It's not just a bladder disease. The first book to talk about phenotyping. We nailed it. I'm very proud of that book, which came out 3 years ago. This is a great achievement for the IC Network and for me in particular. We have all the supplements. These supplements are as cheap as I can possibly make them. We have really good volume discounts. So if you buy more than, I think, 8, you get 20 to 25% off. And so, and a lot of people buy a year's worth at a time. I just had somebody buy a year's worth. What were they buying? Pre-Leaf. Might have been. Oh yeah, it was Pre-Leaf. He was a truck driver. It was very cool. We had a great conversation. Christine said, "What supplement were you just talking about?" It's called Peora. PEA 500. So, for anybody with sensitization, I see subtype 5, you struggle with really sensitive skin, you got pudendal neuralgia, anything at all like that where we know the nerves are jacked up. This is pretty remarkable stuff, and the research is phenomenal. And you can research it yourself. You can go to the National Library of Medicine and look it up. Let me just, I'm going to type it out separately on YouTube. This is, hold on, I put my mouse in the wrong place. Palmitoyl LM. Hold on. ITOY. Oh, come on. ITOYLTPHANOLAMID. Okay, that's the scientific name, Christine. And the brand name, the one that we do, is PEA 500, aka Pura. And that's in the IC network shot. There you go. Where he says, can you tag me in the store? Here, I'll just put the link. I think that's a link for Pura. So Brenda, PEA, palmitoyl ethanolamide. So let's talk about this for a moment. I knew as a support group leader about PEA years ago, 20 years ago. We had a doctor down in Southern California who was actually importing it for his patients from Europe. It is an endocannabinoid. So it acts on cannabinoid receptors, but it is not medical marijuana. There's nothing related to it, like it doesn't cause people getting high or anything at all like that, but it has kind of a similar method of action. So I learned about this 20 years ago at a conference in San Diego, and I actually got introduced to the pharmacist who was importing it for ICers, but it was very, very expensive. And so it really fell off my radar. It was thousands of dollars to get. And so, I knew about it for a long time. We just didn't talk about it because it was just way, way, way too expensive. Well, then in 2019 at the American Urology Association conference, the European researchers brought data from their IC study. And it was shocking. It was so good that when they presented it in the IC poster session at AUA, the doctors were thrilled that they could finally suggest something that was proven to reduce IC pain, that was an over-the-counter supplement with no side effects. Because the PEA has the lowest side effect profile of anything I've ever seen in 30 years. There were no side effects reported in the IC study and in the vast majority of studies out there. And I would encourage you to actually Google it and look at some of the studies. You see if you can find side effects. Very, very few side effects. So, the doctors were just ecstatic that they could actually say, okay, here's something that you could try for pain that it does not it's not an opiate. It doesn't carry any of the risks of the opiate. It doesn't carry any of the baggage of medical marijuana. And it's been in use for decades in Europe. We're actually kind of slow here in the US. And so I will give you the scientific name. I'll spell it out for you right now here on Facebook. So that is the scientific name. Copy and paste it. Go over to pubmed.gov. PubMed.gov is the National Library of Medicine. Type that in there and you look at the research, see what you think. Now, I think you guys need to know that as a pharmacologist, I don't like taking anything. I don't. Super sensitive, redhead. But one of the reasons I went into pharmacology is because when I was a kid, the kid across the street, Craig, suffered brain damage after taking LSD. He took it once. Nerdy kid, math geek, hanging out with some friends. Somebody gave him LSD, took it once, and it destroyed him. It destroyed him. He literally has no brain capacity, and his sister basically keeps him in the country because he can't function. And that was such a lesson for me about the dangers of medications and the dangers of drugs in general, because I witnessed that happening. So anyway, I don't like taking anything, but for me, my skin just got so incredibly sensitive that I couldn't sleep. And I'm looking at the PEA research, and we had the Pure, and I'm like, Jill, what do you have to lose? Give it a shot. And my skin sensitivity is gone when I take this. Now, I didn't take it last night. I was too lazy to get up and get it. And now my skin's a little prickly today. But I also have mosquito bites, so it's hard to know. Christine says, thanks for being here. I was feeling so alone this morning. Christine, you know what this is? This is a hug. Honey, see, you just made my day, because that's, you'd be amazed at the mornings that I have where I feel alone. And I think that there's such strength and comfort in being together and in sharing our stories. And there's nothing quite as wonderful as walking into a room of people with IC. I mean, I remember I did my first conference in 1994, actually, and we had 300 people there. And I walked up to the podium, and standing at the podium at the wonderful hotel that has since burned down. I was just in awe of the smiling faces that I saw that needed hope, but most importantly, I wasn't alone. I thought when I was diagnosed that I was the worst case in the country. That nobody could know how badly I was suffering. And then when I started my first support group, which was called IC Redwood Empire, and I started meeting with so many other patients, context matters. Because I actually saw very, very quickly that I wasn't even close to the worst case. One of the ladies in my group had her bladder removed, and she still had very, very severe pain because obviously it wasn't her bladder in the first place. Right? So there's comfort in being together. And sometimes the most important thing people need to hear from me when I do coaching, because I work with patients every day as a coach also, is there's nothing about your case that scares me. Listen, if you're not peeing blood clots, if we don't have very clear signs of a severe disease happening, like severe fatigue, weakness, blood in your urine, stuff like that, for most of you, you're my sisters and brothers. Okay, yeah, we got some bladder wall sensitivity driving you crazy. You take vitamin C every day? Oh, yeah. Oh, that's a problem. Or did your symptoms start as you got a little bit older? Okay, now we need to look at estrogen atrophy. Oh, yeah, my doctor told me that my skin was getting dry. Did he give you estrogen? Yeah, I did. Did you use it? No, I never used it. Oh, okay. So we can provide a little bit of context here. So Christine, you are not alone. I kind of have this I have two fantasies. Fantasy number one is that I'd love to do a retreat for IC patients for a week. Not a cruise. I don't really like cruises that much for me personally because my ears are a little weird. But I'd love to have a week-long retreat, like in Denver or someplace in the center of the country where we could all just hang out at a hotel. We bring in some speakers, maybe even make it possible to see a couple of doctors while you're there. That to me would be really cool. Then my other big fantasy is I would love if I won the lotto. I would love to buy an apartment complex and dedicate it to patients, especially patients who are alone, struggling with IC and or pelvic pain, so that we could live together and be there and support each other. Those are two of my fantasies. Right back at you, Christine. Right back at you. Sherry says, I love my IC 101 book. Geared it to my pelvic floor physical therapy on Thursday to show her Kegels can be harmful to IC patients, so she would stop having me do them during my session. I ordered Bladder Builder from the IC Network store. Yeah, baby. And you're going to receive it tomorrow. So tomorrow you're also on Desert Harvest Aloe. Well, Sherry, I would encourage you to look at our Allopath. I think that Allopath, because it has PEA in it, actually is a bit more soothing. Patty says, hi, Jill. Hope you're doing okay. How long does PEA take to work? I've been on Allopath with PEA for 2 weeks, but you're not feeling better. Well, what the research study showed was 3 months. And I think the challenge with you taking the Allopath is that you're probably not getting the full dose of PEA. Let me look. Hold on. Oh, and somebody was asking about the probiotic. It's called L-Flora. L-Flora. This is also in the IC Network store. Okay. So hold on a sec. Let me look. Now, of course, I have my computer glasses on, not my reading glasses. He doesn't break it out. I can't answer that question. I would be tempted to, it depends upon your symptoms. If you're having a lot of like what feels like skin irritation, then aloe makes sense. But if you're having more sensitivity, then the straight PEA makes sense, I think. You got to find what works for you. Unfortunately, I can't predict it. The blessing here is we have a lot of options. Sherry Horton, thank you so much for the 100 stars. Very, very appreciated. Sherry says, crazy how many urologists and kind of urologists still tell people with tight pelvic floor muscles to do Kegels. Still don't understand the subtypes, thanks to Jill. Found a national specialist near me and finally got what was driving my frequency, urgency, pressure, pain. Had nothing to do with my bladder. It was literally tortured for 30 years with bladder installations that never helped and other torture treatments. I'm so glad I found Dr. Ken Peters. Luckily, he's only a few hours away. Exactly. Sue, exactly. Sue, you are the case study. I don't know, Christine says, I love your fantasy. Mary says retreat would be awesome. So, I mean, we've talked about your story before, and I'm sure you wouldn't. I think your story is very, very important. Okay. And we've referenced this several times, and you've allowed me to talk about it. And let me just kind of summarize. Sue was diagnosed with interstitial cystitis and tried bladder treatments for 20, 30 years? And at one point in time, you were bedbound, right? And then, I think at one point in time, one of the things that I just say is you are an anatomical mystery to be solved. And what made Sue so interesting is as we started learning about pelvic floor dysfunction, we learned how good pelvic floor dysfunction can be. But when Sue went to pelvic floor dysfunction, it always hurt in one spot. What shouldn't have been painful was painful for her. And that's when we go, okay, what's at that location? That's weird and that's unusual and that's very interesting. And it was another doctor, Dr. Ken Peters, who found out what was at that spot. It was a giant mass scar tissue woven through her pelvic floor muscles, right, Sue? And as soon as he told her what it was, she goes, oh, I know exactly when that happened. I fell off a horse really badly and landed right there. And so that's a perfect case of somebody whose symptoms began as a trauma. The underlying anatomy was entirely pelvic floor driven, misdiagnosed with a bladder disease, wasted how many years trying treatments, money that would never have worked. I did the same thing, just not quite to the same degree as you. And ultimately, in the end, it was getting back to solving your anatomical mystery. My pelvic floor muscles are very, very tight on my left side. Why? Because my SI joint's messed up. Sue says, how long do you need to stay on PEA to see if it's helping? I did do a bottle once a long time ago, but only until the bottle was gone. I didn't think it was helping. Wonder if I should give it another try. Well, it's all about how, are your nerves jacked up? And if your nerves are jacked up and your nerves are super sensitive, then, again, it's about 3 months. That's what the IC study showed. Brenda says, does the IC make you have bladder spasms? Well, Brenda, we got to ask that question in a slightly different way, because IC doesn't mean anything. Interstitial cystitis is, everybody knows, is actually the wrong name. IC is not a bladder disease for most of us. It's a neuromuscular disorder. And that's what our national guidelines say. So, bladder spasms absolutely can happen. I consider a bladder spasm basically your bladder screaming for help. The only times that I've had bladder spasms, so understand you got two different types of muscles in your pelvis. You got your smooth muscle of your bladder, and you've got your skeletal striated muscle of your pelvic floor. Skeletal muscle is muscle that helps you move. It's critical to movement, right? So we've got smooth muscle of the bladder, skeletal muscle of the pelvic floor. They both can go into spasm. Pelvic floor muscles can go into spasm. I was in pelvic floor spasm for 10 months after my hysterectomy. And it was a pulling sensation. It felt like there was a hand up my vagina grabbing onto my bits and trying to pull my scar tissue out of my body. There was, for me, when I had involuntary pelvic floor spasm, it was a pulling sensation. And when the doctor finally agreed to see me after telling me for months it was post-op recovery, he could see my muscles quivering. He goes, wow, I can see it. You have involuntary levator ani spasms. Now, the only time I've had bladder spasms, and bladder spasms are really interesting because generally they happen as the last couple of drops come out of your urethra and your bladder. And so at that point in time, your bladder, remember, your bladder wall's like a balloon, right? And so it fills with urine. And then when you urinate, it collapses. And as it collapses, sometimes the walls touch. And sometimes when the walls touch, they quiver. If your bladder wall's really sensitive and they touch, sometimes they can quiver, and that can feel like a spasm. You might feel a vibration. But I've only had 2 bladder infections in 30 years. And one of them I thought was a flare for 6 weeks. And it was getting worse and worse and worse and worse. And finally, when I was fearing urinating, because I knew that at the end of urination, I would get this violent spasm that would have me bent over the toilet, sitting on the toilet, with my shoulders almost on my knees. The spasm was so violent, and I couldn't move for a couple of minutes. It was just this massive spasm that shot up my spine and down my legs. And once that started happening, I think it was over a weekend, the next day I just walked into my urologist's office. I didn't even call him. I just walked in sobbing. And they had never seen me cry. I ran their support group. I ran the only bladder support group sponsored by Kaiser Permanente for 15 years. And I was their support group leader. And they had never seen me cry. And they saw me crying, and they just grabbed my arm, pulled me right back in to the office and sat me down and said, what's wrong? And I described what was happening. And she goes, Jill, don't you know you're having a bladder spasm? And I went, no, I've never had this before, and I don't like it at all. It's awful. And they tested my urine. I was very, very infected. And they gave me ditropan, which is an antispasmodic, smooth muscle antispasmodic that turned the spasms off in 20 minutes. And so I got through that round of spasms with just a couple of pills of ditropan. So it's hard. It's hard to distinguish between a smooth muscle bladder wall spasm versus a skeletal muscle pelvic floor spasm. If your spasm is occurring as you're urinating, then we're really looking at the smooth muscle of your bladder, and you have to use a smooth muscle antispasmodic like ditropan. But if your spasm is happening at other times, not while you're urinating, and if you have symptoms when you're moving, you're walking, or when you're sitting and gets better when you're standing, that's muscle. That's pelvic floor spasm, most likely. I hope that makes sense. Does that? Christine says, you're the icy fairy godmother. That's what I want to be. And I'm filling my house up with butterflies now. Now that I get to move stuff around, I've got butterflies everywhere. And I've got fairies everywhere too. Because I'm sorry, I believe in winged things. They make me happy. Jody says, I joined the ICN today and bought all of my books and supplements from you. Thank you. It's the least I can do for all the help you've unknowingly given me. Jody, thank you so much, hon. Thank you. Sometimes when I'm working, I wonder if it's helping, and I'm so glad that it did. I'm so glad that we are helping. I mean, I know we are because I get lots of emails and stuff, but it's a lot of work. Marlia says, Jill, I told my primary doctor about PEA and your teaching. She and her office pharmacist looked it up and called me to say I taught them both something very valuable and are very excited to have this info. I have fibromyalgia and IC, jacked up nerves, and they are encouraging me to keep a diary once I start it. They were impressed with your teachings. You taught them big time. Yeah. Yes. I mean, see, the thing is think about how do doctors get their information? Well, number one, they get some of it through med school, but you got to understand med schools are far behind the times. And do they have the time to read the journals? No, they're working just as hard as everybody else is working. We're all working crazy now, and since COVID, and even before COVID. Businesses are downsizing. I mean, I just, in my role here at the IC Network, and I have got a couple of employees too, but I'm the lead writer, I'm the lead video person, I'm the lead researcher, I'm the lead patient coach. I do at least 4 jobs in my job. And so we have to respect the fact that they simply don't have the time to do what we can do, and just respect them for that. We don't want to disrespect our doctors. For God's sake, we need them. And coming in, my rule when I go to the doctor is I always bring a gift. And my gift is something useful. So I'll bring them IC 101. I'll bring them an article. I'll bring them some magazines. I will. And they've never been mad at me for doing that. Oh my God, my nose is crazy. Hey, let me move these flowers, okay? Oh, there's something in this flower arrangement that has got me. Okay, so now you can see my scissors. There you go. My eyes are all itchy too. Sharon has a video, how to use a pelvic wand. Excellent. Sue says, what's Dr. Peters' contact information? Where is he located? He's in Royal Oak, Michigan. And all you need to do is just Google Ken Peters Urology and you'll find him. He's the chairman of the urology department at Beaumont Health, which has a new name. It's not Beaumont anymore. It's like Covello or something. Let me look it up. Ken Peters' office is, in my opinion, the best research team in the world. Corewell. So Beaumont is now known as Corewell Health as of October of last year. Corwell. Sue said, I did the same thing with 2 bladder infections I ever had because you cannot tell they're bladder infections and ended up in the hospital. Once when they went to the kidneys, if a flare goes on too long, I just call my primary care and she has me going for urine culture, but I will not take any antibiotics until the culture comes back. Good strategy. I like that. Brenda says, thank you for that answer. It was very helpful. Thank you for all your time and your help. The pain is so terrible. Sometimes you do feel all, I know you do. It's very hard, especially with something that you can't really talk to people about. You know, this is very humiliating to have to talk about bladders and all that sort of stuff. Kathy says, how do you find out if scar tissue is the issue? I've had ultrasound, CT scans with or without dye. How would they find it? I had hysterectomy several years ago. A physical therapist would find it. It's really about touch. Scar tissue feels like beef jerky. It's tough. It's rigid. It's binding. Whereas a good normal muscle tone feels like a raw chicken breast. So the way you're going to find it the most is with the sense of touch. The physical therapist just has to touch it. And you had your hysterectomy. I got to tell you, that hysterectomy was rough. That hysterectomy was rough on my pelvic floor. I was not a happy person. The spasms started about 6 weeks afterwards, and they went on for months and months and months. And I finally got into the doctor, and he saw the muscles quivering. And he goes, well, Jill, I know exactly what you have. You have involuntary levator spasms. And I'm like, okay, what do we do about it? He goes, physical therapy. I'm like, all right, sign me up. I'm ready to do it. And he goes, well, I need to warn you, most women drop out. And I said, why? And he goes, because it hurts. And I said, well, number one, I'm not most women. And I want to do it. I'm going to do it. Sign me up. And I never found physical therapy painful when they were doing it. I'm one of those people where I laugh. I don't cry. I laugh during procedures like that. So the more I laugh, that's when it gets it shows that I'm a little bit more uncomfortable. But I never found a physical therapy remarkably painful at all. But I knew as soon as I got off the table and put my clothes on and walked out to my car, that's how I knew that they had worked with the right muscles. And so for me, after my first physical therapy appointment, yes, my muscles were rock hard tight. As I walked out of the car, I was like, okay. I feel this. This doesn't feel good. And as soon as I sat down and in my car, the act of sitting, going from standing to sitting, was brutal. And I burst into tears and I sobbed all the way home. And came home and took a muscle relaxant in my heating pad, and I laid in the recliner for 8 hours. But I went back. I'm not going to give up, man. I'm going right back. I go back the second time. I tell her what happened. She goes, okay, this is important to know. We do the physical therapy again. The physical therapy didn't hurt till I got up and walked out. And again, when I sat in my car, I cried. But I didn't give up. I went back. And the third time was a charm, because the third time she worked with the muscles, and guess what? It didn't hurt when I sat down. And so sometimes we have to work through that. We have to work through the healing process. It can hurt, but muscles respond beautifully to physical therapy, and it's worth doing. Don't give up. Keep doing it. Kathy says, those spasms are similar to what I'm experiencing, but the mast cells in my bladder are throwing me off. Can the pelvic floor cause mast cells in the bladder? No. No. There are mast cells throughout your body. How do I want to answer that? You probably have a little bit of both going on. I mean, if you've got a lot of mast cells in your bladder, then that means your bladder is quite inflamed. There's something that's been provoking your bladder, like an allergen. If you have allergies anyway, hay fever, that would help us understand why you might have more mast cell activity in your bladder also. That's the people who respond the best to the antihistamines for their bladder, or the patients who also have hay fever, right? But you have the chicken versus the egg. If your bladder wall's fried from whatever, of course your muscles are going to get tight and try to protect you from that pain. That's called the guarding response. So you might have to treat both, and that's okay. You can do it. Arlea says, do you know anything about, you guys, let me just say here, if you've asked a question and I've missed it, don't take it personally. I just missed it. Please ask it again, okay? Because my screen moves very, very quickly. Jill, do you know anything about the muscle relaxer called metaxalone? My doctor said she wasn't a fan of baclofen. My whole body muscles are so tight, some days I can barely walk. Can metaxalone be an okay choice, but as good as baclofen? I can't say that it's ever come up in the groups that I've worked with and the classes that I've taken. Hold on. Hold on. Metaxalone, or is it? All right. So hold on a second. Let me look at it. It can relax certain muscles. Interesting. Okay, hold on. It's used to treat muscle spasms or pain. To prevent a very serious high blood pressure reaction, it's very important that you follow a special diet recommended by your doctor to limit your intake of tyramine while you're taking this medicine. Avoid foods and beverages that are high in tyramine, including aged cheeses, dried meats, sausages, preserved fish, products that contain a large amount of yeast like bouillon cubes or soups or gravy or sourdough bread, fermented foods, moist soybean products, broad beans, red wine, sherry, tap, beers, and vermouth. Where their information is quite poor. Hold on. Let me see if I can get better information. Let's go to WebMD. Or let's go to drugs.com. It works by blocking nerve impulses or pain sensations in the brain. It's used together with rest and physical therapy to treat skeletal muscle conditions such as pain or injury. You should not use it if you have anemia. or severe kidney or liver disease. They don't know if it's going to harm an unborn baby. I don't think it would be something that I would choose for myself, because I also already need to be careful with my blood pressure. Tiffany says, what is the Elmiron news? Can't find it and just saw that. Tiffany, Elmiron has now been linked to a severe inflammatory bowel disease and something called dysplasia. I can, you know what? Why don't I just go through this again real quick? So it was the eye researchers who were studying the eye complications with Elmiron who started seeing that many of the patients they were working with also had inflammatory bowel disease. And they explored that further, and they now believe, they aren't the first, and I went back to 2005 to research, to believe that the Elmiron is playing a role in, and as they say, is strongly associated with inflammatory bowel disease and dysplasia. So dysplasia is very bad because it basically means that the structure of the bowel has changed, the cells have changed dramatically, and these are cells that are then known to cause cancer. So this is deeply concerning. Some IC patients using Elmiron have had to have a colectomy. They've had to have their bowel removed because the damage is so profound. So as an example, let me just kind of go back to the beginning here real quick. Hold on. So the ultimate message here is if you're on Elmiron and you're having any severe bowel disease, you have got to let your doctors know, because the other thing that's very important is for, especially early on, patients who had rectal hemorrhaging and more severe symptoms, once they stopped Elmiron, it went away. And so the first published paper about this was in 2005. And it was called the pentosan polysulfate drug-induced colitis. And it was published by Texas A&M in Temple, Texas. And they shared 2 case studies. A 29-year-old woman who developed bloody diarrhea and crampy abdominal pain 1 month after starting pentosan. When they looked in her bowel, they saw ulcers, friable colonic mucosa, hemorrhage, and the treatment with the typical medications did not help at all. But when they discontinued the Elmiron, the symptoms went away. Okay? And the repeat colonoscopy showed a resolution of a colitis and normal tissue again. Case number 2, 59-year-old female with history of irritable bowel, including irritable bowel syndrome, developed increased diarrhea and lower left quadrant abdominal pain 2 weeks after starting pentosan. Colonoscopy again revealed some pretty alarming changes in her bowel, including some fibrosis and necrosis, tissue death. Abdominal pain and diarrhea improved upon discontinuation of the pentosan polysulfate. And as they say here, pentosan has been shown in animal studies and human studies to be associated with drug-induced proctitis, which relates to the rectum. The clinical setting, time course, histological findings, endoscopic patterns, failure to respond to anti-inflammatory, and resolution upon withdrawal of pentosan suggest a causal relationship. Okay, so those are the first 2 case studies published. Then in 2015, we have another case of a 32-year-old woman with a past medical history of IC presented for an evaluation of chronic diarrhea for 7 months. She had loose bloody stools and approximately 20 bowel movements per 24 hours. This was associated with cramping. Again, they did the exam, they ruled out Clostridium and all that sort of stuff. And when they discontinued the Elmiron, her symptoms resolved. And you know me, I love pictures. This picture has no relationship to it, but I want to show you a picture. You see that picture right there? That relates to this article. That is a worm. This poor guy had it's a parasite endemic to tropical regions that was found in his bowel. Okay, anyway, I'm sorry, show and tell. I love that stuff. Okay, then in 2015, we have another paper, although this one it was about changes in liver enzyme levels. That a patient's liver enzyme levels after starting Elmiron changed dramatically. A 32-year-old female. And once they stopped the Elmiron, everything normalized. And then in 2023, here's 2022. We have another case study. No, hold on. I'm sorry, the writing's really small. 30 patients who met the criteria were identified. So these were patients who had interstitial cystitis and were on Elmiron and had a diagnosis of inflammatory bowel disease. Of these, 10 had colonic dysplasia, low grade or high grade. Of the patients with dysplasia, 6 required a colectomy for endoscopically unresectable dysplasia. Following physician consultation, 3 patients discontinued the drug and subsequently demonstrated clinical benefit and achieved endoscopic healing. Okay. And then last month, we have our first really big paper, which is a case series of, so let's see. So hold on a sec. So where is this one done? This was done at Oregon Health and Science University and Stanford Healthcare. They identified 30 patients with IBD who had past or current use of pentosan for at least 2 years. 10 developed dysplasia. Okay, that's the same one. And now we have our first fairly large paper. This is still waiting for peer review from the researchers at the MRI Institute. And they make a much stronger case for this. So, you know, we are exactly where we were when we launched the pigmentary maculopathy, which I announced in one of these meetings. Donna, what the hell? Donna, I just got out of the hospital with a UTI. You had to call 911, just shy of being septic, never had a UTI, screaming in excruciating pain, morphine, and now on oxytocin. Internal doctor did every test and some imaging. You were dehydrated. Oh, honey. You know, listen, you have been through some serious trauma, and with all your traveling, your body is, you know, has been challenged in many, many ways. And yeah. Oh, life. Anna says, does it say if Elmiron has caused rectal prolapse? They use the term collapse with respect to, how did they use that term? Like an architectural collapse of the cells? I think it's possible. But I just don't know. It's possible. It is potentially possible. But I have to say this over and over and over again. They have not established direct cause and effect. At this point in time, they're calling it a strong association. But I think we really clearly have to look at these all published case studies, because these published case studies show that when patients stop the medication, they heal. So that's pretty compelling information. So again, our big concern here is kind of like levels of inflammation and irritation. So we might start seeing some minor inflammation in the colon, then it gets progressively worse, and then it gets so severe that the cells are actually changing. That's called dysplasia. And these cells that have changed are now run the risk of becoming cancer. So dysplasia cells are kind of precursors to cancers. So this is really quite alarming. And we certainly want to let as many patients know as possible that if you're on Elmiron and you're having bowel issues, that you need to bring this information to your doctor, because you're going to have to make some pretty important decisions about whether you're going to continue it or not. Because for these severe dysplasia patients, the only treatment is to remove everything. And that's not good. Sue said, did these cells mean the same thing as precancerous polyps when you have a colonoscopy? I don't know. I think polyps are separate. See, I'm all itchy now, guys. You know what? Hold on. I'm going to go take my pee. Oh, wait. It's right here. No, wait. That's an empty bottle. Hold on. Where is it? All right. I got 5 left. Gonna have to order some more. Christine says, what is PEA made from? Well, I think in its earliest forms it's derived from eggs. I am not sure right now. Donna, honey, you don't have to pay for a thing. Do you hear me? No paying. Okay. Sue said I was only on Elmiron for 3 years, but do get colon polyps every 4 to 5 years that have to be treated, but family have history of them. That's probably family history. Sharon says, rub some lemon on the mosquito bites to stop the itch. The challenge when you have central sensitization is that your nervous system gets jacked up if you have something that hurts. And so all the nerves come back and become a lot more sensitive. And so, you can see I've got a mosquito bite. Is it right there? I'm trying not to touch it. It's right there. I got a mosquito bite there. I got another mosquito bite right there. I got a mosquito bite on my shoulder. I got a lot of pain generators going on right now, which are jacking up my nerves, and I don't like it. So annoying. I hate biting bugs. With a passion. My nerves all over. Donna says my nerves are all over the place right now. Yeah, exactly. I would never survive living up in like Montana and Minnesota with all those biting bugs. Oh my God, never. Avery says, is there a form of IC that is autoimmune but doesn't cause ulcers? It causes visible bladder inflammation, but not ulcers. Generally, what the researchers are saying is that the autoimmune autoimmune issues are really more implicated in Hunner's lesions. So if you have Hunner's lesions, that's where, and think about cyclosporin for a moment. So cyclosporin helps to suppress the immune system, right? And cyclosporin is really, in the old system, it was a step 5 treatment. The reason why it was a step 5 treatment is that there's a lot of side effects associated with cyclosporin. But cyclosporin's actually been a bit of a miracle drug for some patients. And particularly in patients with Hunner's lesions, if I remember correctly. Let me look at something real quick. Hold on. I want to go to Curtis Nichol. Do you guys remember that Curtis Nichol up in Canada, the top IC researcher up in Canada, proposed 9 subtypes? I've been using Chris Payne's 5 subtype system for 6-7 years now. And Curtis Nichol, and it's a blog on our website. Yeah, it's right here on the front page of the IC Network, icnetwork.org. It's a color wheel on it. So he gave us his proposal for 9 distinct types of IC, and he also published his recipes for treating each type. And so Dr. Curtis Nichol, the preeminent IC researcher and clinician in Canada, offers a new proposal of 9 potential phenotypes, subtypes within the IC community. He wrote, quote, "I've been asked by urologists many times over the decades how to treat a specific patient with IC and found that I gave a different answer based on each patient's clinical picture. And he's also found that a stepwise monotherapy approach is doomed for failure in the majority of patients." Now, we know that. We know that bladder treatments do not work for the vast majority. Now, understand his credentials are impeccable. 24 clinical trials. He's done 200 IC studies, written to 600 publications, presented courses in 45 countries, and as a professor at Queen's University has worked with hundreds of patients. I will tell you that Curtis Nichol is probably the best writer of all the writers out there. I literally read everything he publishes. So he uses a concept of a recipe to describe a patient treatment plan. Each recipe begins with some common ingredients. He encourages patients to be willing to learn about IC and to be proactive with their diet and exercise. Eliminating foods that are known triggers is an easy first step. To trigger the production of endorphins, natural painkillers, low-impact exercises are suggested with a caution to avoid exercises that put pressure on the perineum, like biking. He encourages positivity, mindfulness to help in healing and improved outcomes over time. Okay, now this is interesting. To physicians, he reports using DMSO and Elmiron less frequently due to both short and long-term risks, such as retinal disease. He encourages the use of pain management early in all patients, including NSAIDs, acetaminophen, urinary analgesics. He believes that the long-term use of opioids should be avoided because they restrict the body's natural opioid production and fail to provide pain benefit over time, and that's quite true. He notes, however, that the strategic use of cannabis seems to help patients cope better. He wrote, "It is imperative that pain outside the pelvis associated with IBS, fibro, chronic fatigue, and back pain be managed. Pain left untreated acts to upregulate the nervous system," which I am a living example of right now, making it more sensitive to pain. They may require multiple specialists, including a urologist, gastroenterologist, etc. Surgery is the very last resort, and only for patients who have tried all other therapies with no success and or have an end-stage bladder, which is a bladder that has lost its ability to expand, to hold urine, and it may be fibrotic. Interestingly, he also established a nurse-based intravesical treatment clinic on Friday afternoons for regular treatment and for flare management, noting that flares seem to occur more frequently just before the weekend. Okay, so what are his subtypes? You're going to like this, Avery. Subtype number 1, inflammatory IC BPS. This subtype includes patients who have visible inflammation on the bladder wall or Hunner's lesions. If lesions are present, Dr. Nichols suggests that they should be cauterized multiple times if necessary. After successful treatment with cauterization, Dr. Nichols switched to steroid injections into the lesion. For early or mild recurrences, he suggests using a classic rescue installation, including lidocaine, triamcinolone, and chondroitin sulfate, or heparin, or sodium hyaluronate. And for patients who do not respond to these treatments, oral cyclosporin has been successful. So I remembered it correctly. Number 2, infection-mediated IC-BPS. Now, this is interesting. He's the first person to make this direct correlation. This is a new subtype that no other system recognizes. Dr. Nickel argues that there are patients who have a history of recurring UTIs who may be experiencing, quote, a bladder hypersensitivity syndrome secondary to the infection. While long-term antibiotic therapy is an option, Dr. Nichols suggests applying antibiotics directly to the bladder via a bladder installation. Now, isn't that brilliant? I mean, what's the flaw with taking oral antibiotics? Is you're going to mess up your entire body biome. If you got a freaking bladder infection, put the antibiotic directly in the bladder. That's a much better way of doing it. He also shares the results of research with a new UTI vaccine, which their study showed significantly reduced recurring UTIs. It's called NV140. Okay, his third subtype is neurogenic hypersensitivity. These are patients with widespread pain conditions. That's just IBS, fibro. The goal of therapy is to calm nerves in the bladder and the central nervous system. Okay, number 4 is multiple allergy IC. These patients struggle with respiratory, environmental, or dietary allergies. He says they can easily be identified during a cystoscopy by gently poking the bladder wall with the tip of a cystoscope. And if by poking the bladder wall, it swells and gets a wheal infection, a little area of redness, right? Then he believes that that's a sign that this is somebody who has multiple allergy-driven IC. His 5th subtype, pelvic floor. His 6th subtype, primary storage syndrome. These are patients who have pain as their bladder fills with urine. He believes that these patients can benefit from an antimuscarinic medication like mirabegron, and he thinks that sacral neuromodulation might help these patients the most, but it doesn't help with pain. His 7th subtype is urethral pain syndrome. He believes that the patients with urethral pain are the most difficult to treat. These patients have pain in the urethra. Sometimes it's their only symptom. It can be constant, episodic, or associated with urination. That's where we look at nerves and muscles and estrogen atrophy. His 8th subtype is pain with intimacy, and his 9th subtype is flares. Oh, you can read this article right on our website. Go to icnetwork.org, scroll down, and you're going to see a blog that has a color wheel on it. That's what I was just reading. Now, I am compelled to repeat something that we learned at AUA. What did I do with my slides? Wrong slides. I've got another big development that I talked a little bit about last week. So again, we know there's diversity in the IC patient population. We're not all the same. For some of you, it all begins after you break your tailbone. For others, it begins after chemotherapy. Okay, there's no doubt there's tremendous diversity in this patient population. But as Dr. Nichols says, he believes that there is a UTI subtype. So at AUA this year, Dr. Ann Ackerman from UCLA did the most fascinating discussion of the urinary biome. So what's a urinary biome? The urinary biome is what's living in our urinary tract. all the beneficial bacteria. Urine is not sterile. Remember, our body needs and operates with the help of millions, if not billions of bacteria. Well, millions. I'm not sure if it's billions, but anyway. Bacteria do things that our body can't do. Bacteria produce food that our body needs. Bacteria help to maintain structures. Bacteria do amazing, amazing things in the entire body. And so as they've been doing the Human Biome Project with next generation DNA urine testing, they're now understanding what's normal. And we have our most research in the bowel, right? And so not as much research in the urinary biome, but we're getting there. And we're trying to understand certain roles that these beneficial bacteria play. And really, it's a question of what's normal. Is it normal to have E. coli in your urine? Yeah, it might be. If you're over the age of 45, it might be completely normal. So anyway, this is what she talked about. Up to this point, the IC research studies, they were looking for their smoking gun. They were looking for the big bacteria, which could be causing all of this, like Helicobacter pylori, which causes all stomach ulcers. And what the next generation DNA studies found was that the IC biome is virtually normal, that they did not find a smoking gun. What they did find is that our bacteria were a little bit less diverse, and we had more lactobacillus than normal. Now, lactobacillus is good beneficial bacteria, right? So multiple studies using many, many different methods found this, that not normal biome, a little bit less diverse, a little bit more lactobacillus. Well, she decided to take a closer look at it in her science lab. And one of the flaws of the original studies is that they lumped women of all ages in the study. And for the guys watching this out there, a couple of studies have looked at the male biome, but they're predominantly looking at the female biome. But don't worry, it's happening. Okay. So here's the thing that we know. The biome changes as you get older. So she broke the data apart by age. So patients under the age of 45, patients over the age of 45, okay? And that's where you started to see trends. You started to see trends. So in the normal 45-year-old control group, no bladder symptoms, their biome is dominated by lactobacillus in a very, very healthy way. But in somebody who's older, in women who are older, lactobacillus is still dominant, but to a much lesser degree, that there are significant populations of E. coli and Corynebacteria and a couple of others. And so the older we get, pH changes, hormone levels drop, it becomes a much safer place for bacteria, right? Okay, so now we have normals. So we have asymptomatic older women with an active population of E. coli, and they have no bladder symptoms. And so that's then telling them, okay, maybe E. coli is supposed to be there for some of us. It is supposed to be there for some of us. The question is pathogenesis. Is there a bacteria that is doing damage? So those were the control groups. So now she started looking at the IC patients who were under the age of 45 and IC patients over the age of 45. And she started looking specifically at the good bacteria, the lactobacillus. And she made an absolutely stunning discovery that patients struggling with bladder wall-driven symptoms under the age of 45 had a dominance of a specific type of lactobacillus called Lactobacillus iners, I-N-E-R-S. Lactobacillus iners is the only gram-negative lactobacillus. It's a bad lactobacillus. It's bad. Normally, lactobacillus eat fungus. They control the fungal population. Lactobacillus iners does not control the fungal population. Lactobacillus does not perform the main functions that lactobacillus perform. And most importantly, lactobacillus iners releases a substance which directly damages cells, just like Gardnerella, or what was the other one? Proteus. Anyway, so some bacteria are particularly pathogenic because they secrete substances which destroys tissue. Well, lactobacillus iners, what we thought was a beneficial lactobacillus, is actually not beneficial at all. It's actually harmful. Okay, so now she finds the iners, which is, really quite amazing. Like, wow, okay, this is weird. Where's all the other lactobacillus? The other lactobacillus aren't there. It's just the iners. So then what she did is she applied the subtypes to her data. And what she found was that patients who were pelvic floor dominant had a normal biome. Patients who were bladder centric, again, had an overabundance of lactobacillus iners. And patients who had the urethral pain had an overabundance of E. coli. So this was mind-blowing. Absolutely mind-blowing. So this was on the class on IC taught at the American Urology Association last month. So then she brought up one of the other correlations, and this was a correlation that the National Institutes of Health IC team discovered, is that some patients who are flaring with severe bladder wall pain have an overgrowth of fungus in their urine, candida. And that research shows the higher the levels of fungus in the urine, the higher the levels of pain. That's an undeniable fact that has been proven by our own National Institutes of Health MAP Research Network. So then she's going, well, isn't that interesting? Because if somebody's dominant in lactobacillus iners doesn't kill fungus like the other lactobacillus do. And so that helps kind of confirm maybe the role that this bad lactobacillus could be playing in some IC patients, but certainly not all IC patients. So I was really, really fascinated by that. So then I'd start reading about lactobacillus iners and do my normal geek thing. Lactobacillus iners is very, very difficult to culture. It takes a blood agar plate, and it has been very elusive for many, many years to researchers. They have now created a new way to culture it. So that's good. And then I found another paper from Massachusetts General, and they found a correlation with the amino acid cysteine. So amino acids are, there's a finch. Amino acids are building blocks for proteins, right? They're building blocks for tissue construction in our body, et cetera, et cetera. Amino acids are important. So what they found is that patients who were dominant in lactobacillus iners had very little cysteine. They were cysteine deficient. And it turns out that all the other lactobacillus need cysteine to grow. But lactobacillus iners does not need cysteine to grow. And so one reason why somebody may become iners dominant is because their diet is too low in cysteine, which is why I ate 2 pork chops this week, because pork is high in cysteine. So I know that that's a very, very complex, but I was talking with Vicki Ratner yesterday, the founder of the ICA years ago. Had a nice long conversation yesterday, and I was telling her about all this research, and she was fascinated by it. So for those people who are saying everybody with IC has infection, well, number one, you're full of crap. Absolutely not true, because so many patients' symptoms are the result of drinking too much coffee or tailbone injuries. But there certainly is a subset of patients who could have more bacterial origins to their symptoms, as Curtis Nichols suggests. And now we have a pretty interesting and very different approach that might not be an E. coli or something like that, that it could actually be an imbalance in the lactobacillus in the system. The good lactobacillus have died. The bad lactobacillus is now thriving, which is allowing fungus to overgrow, et cetera, et cetera. So that research is very new and it's very exciting, but they're not ready to draw big conclusions yet. Sue says, let's see, hold on. It was awful pet grooming for 40 years and being allergic to I can't imagine. That's one of the reasons why I don't have pets right now. I mean, I would love to have, like when we talked, Sue, I said I was going to get a dog. I am going to get a dog. Not yet. I'm not going to make any big decisions for at least 6 months. I got to not care for anybody but me for a period of time. Christine said, I just ordered the PEA and the IC 101 book. Excellent. I really hope that the IC 101 book is going to help. Okay, hold on. I got to scroll up. Mary says, Mary, I need to check the dates with my husband. However, I was very ill. You went from 240 pounds to 113 pounds within about 5 months with severe diarrhea and nausea. This was around the time I was on pentosan, and when I stopped the drug, the diarrhea resolved. Exactly. Patty says, are all fermented flares bad in the flare? No. It's about finding what works for you. I personally don't eat a lot of green foods. I love carrots. I love radishes. I love avocados. That's green. Yes, I know. I'm going to make a poke bowl tonight for dinner with rice and veggies and a nice Asian vinaigrette on top. Mary said, I'm not sure if it was IBS. That's what I was told I had related to the pentosan. Also have eye issues, and I'm told it's not anything related to the pentosan. Mary, I got to tell you, this is when you can get the article now. When I write my article for the IC Network, I will have a link to the original study. You can go and print that out and give that to your doctor because it's possible. Would I dare say probable? Maybe. Sue said, I'm curious why pyridium helps bladder pain when bladder installations never did. That's weird. I don't know. Different mechanisms of action. Avery says, my doctor did a hydrodistension. I have a huge bladder capacity of 1.9 liters. Holy shit. He said my bladder wall inflamed, especially the trigone. I've exhausted all treatments except for Botox and cyclosporin. I'm wondering if my IC is autoimmune since bladder installs and meds have never helped me. Gone in and out of remission most of my life, starting at the age of 9. I have terrible burning pain. I'm wondering if I should try cyclosporin. Avery, before you do that, you need to get your muscles checked. You know, generally, when we look at patients whose symptoms begin in their childhood or in their teens or even early 20s, we're always looking for injury first. So do you have tight pelvic floor muscles? Is there, go back to the age of 9. Can you remember any accidents? Did you fall? Did you break your tailbone? Did you break a leg? Were you hit by a car? Anything at all like that? I want to know what the health is of your pelvic floor. Yeah, I'm all itchy. I'm sorry, guys. I'm just all itchy right now. Everything's itching me. What are Dr. Nichols' books that I can get somewhere? He doesn't write books on, I'm talking about medical journal articles. Sharon, thank you so much for the 50 stars. Really appreciate it. Vicki Newman is listening in. Hello, Vicki. Christine says, have I heard of Hyprex? Yeah, Hyprex has been out there. It's not a treatment for IC, but it is a treatment that some patients have used. Vicki says, I didn't get recurring E. coli UTIs until I was in menopause. Very common because with menopause, your skin is drier. Now the bacteria can much more easily reach the cells and infect the cells. Avery says she does not have pelvic floor dysfunction. So Avery is an example. Let me give you an example. Do you ever feel a heaviness, like you're carrying a bowling ball around in your pelvis? You ever feel a weight, an unbearable weight? Here, I'll be right back. I need to get a rubber band. Hold on. It's got to stop messing with my hair. I should just start off in a ponytail every meeting. Okay, good. You don't have the heaviness. What about endometriosis? Do you have really, really painful, bloody periods? Okay, Mary says she has the bowling ball. Mary, the bowling ball is pelvic congestion syndrome. It's blood pooling in your pelvis and swollen blood vessels. And it's very, very easily treatable. So now we know what that symptom comes from. So Avery says, not a heaviness. You had endometriosis removed by a surgery. It did nothing to help my IC at all. So Avery, do you have super sensitive skin like I do? Do you have a wicked sense of smell? Can you smell things that other people can't smell, and do smells drive you crazy? Vicki says, what did I take for that itching? I haven't taken anything yet other than the Pure, which I just took a few minutes ago. No, you do not have any other sensitivity. Do you have dry mouth? Dry eyes? Laura, you have what? Laura says, I do. Do you have the dry mouth, the dry eyes? You were tested for Sjogren's. You do not have the antibodies. Okay. But you do have endometriosis. How about anxiety disorder? Do you have anxiety? Do you struggle with anxiety? That's a very important reason I asked that. I'm not saying IC is a mental disease at all, but it's a sign. It tells us the state of your nervous system. So do you struggle with anxiety at all? Okay. Do you have any other pain conditions besides the endo? Do you have IBS? Do you have vulvodynia? Do you have TMJ migraines? And for you guys on YouTube, I'm sorry, I have you on slow mode because people get crazy on YouTube and come in and crash it. So you can only post once every minute. Sorry about that. You have no other pain conditions, but you've got anxiety. Vicky says, oh God, yeah, you bet, vulvodynia, bruxism. Okay. So again, when we think about subtyping, there is one population of patients which are very different than the other patients. And that's patients who have sensitivity and or widespread pain. So again, for me, I had frequency urgency in junior high. I had severe vulvodynia in high school. I felt like I had a yeast infection, but I'd go to the gynecologist, the beautiful Dr. John Renfrey, and he'd go, Jill, you have the most sensitive skin I've ever seen, but you don't have yeast. Then in my early 20s, I developed irritable bowel syndrome. Then I developed migraines, thank God, only for a couple of months. And then I developed all these crazy sensitivities. I mean, that's, you know, just, and then when I was 32, that's when I had severe bladder pain for the first time. And throughout it all, I had terrible anxiety disorder, terrible. And when you're that patient, you know, I was very isolated in my 20s. My friends were out getting married and having babies. I was laying in the fetal position in this bathroom over here every morning for about an hour or two because my bowel spasms were so incredibly severe. And, you know, you feel you're just a lost soul on the inside. It's like, what next? And people are, you know, you're giving you the shade eye. What's wrong with Jill now? What's wrong? I still have a very, very dear friend that still, I'm sure, thinks I'm a little bit nuts. And, you know, my self-esteem plummeted. My anxiety was very high, et cetera, et cetera. Okay, so the first thing that happened in the research movement was when they started researching nerves. And what they saw was that we call it the pepperoni pizza algorithm, that if you irritate the bowel, the bladder becomes irritated too. And if you irritate the bladder, the bowel becomes irritated. Okay, that's kind of interesting. We call that neuro crosstalk. Why does that happen? Because the nerves merge up at the spinal cord. So think about it. You've eaten pepperoni, the toxins in the pepperoni tweak your gut like mad. So now the nerves in your bowel are very, very irritated. That inflammation quickly spreads all the way up to the spinal cord, and that starts affecting the other nerves at that same area, including the nerve in the bladder. So now the nerves in the bladder are provoked. So that was fascinating. And then we started learning about genetics, that sometimes some patients in families struggle with sensitivity. Redhead. Okay, so my mother always had bladder problems and skin problems. My sister, my aunts, my grandmother was diagnosed with IZ at the age of 92. My cousins. It's like, oh, wait, well, you mean I can inherit some of this? Wow, okay, definitely not my fault. Not my fault if I have other family members who have kind of the same thing. So that really helped us focus on nerves. And really in the last 10 years now, we have acknowledged the fact, the researchers have acknowledged the fact that there are a very significant group of patients who have widespread pain, characterized by very sensitive nerves, very sensitive skin, wicked sense of smell, anxiety disorder, et cetera, et cetera. So researchers came together again about 10 years ago and formed the Chronic Pain Research Alliance. Kathy, girl, we're going to fix that. You hold on tight because there is a happy ending here. This is going to sound a little weird and kind of scary at first, but there's nothing to be scared of. Very, very happy ending at the end, okay? So anyway, so we now have these expert researchers in IC and fibro and migraines and TMJ and vulvodynia working together to try to understand the underlying causation. And they, of course, started looking at the nerves. They started looking at nerves in the pelvis, then nerves in the spinal cord, and nerves in the brain. And they made some rather remarkable discoveries that somebody with widespread pain has a very different brain than somebody without widespread pain. And I didn't talk about that in these meetings. Avery, you hold tight because I'm going to come to that. You just hold tight. So I didn't talk about all these brain studies in my meetings here. Number one, because I thought they were kind of scary. And number two, I didn't really understand them well. But I went to a conference a couple years ago that completely explained it. It's not scary at all. So this is what they found. Somebody who struggles with widespread pain, when you look at their brain, what you see is that they are in a constant state of fight or flight. That 24 hours a day, 7 days a week, their brain thinks their life is at stake. So we have two nervous systems. We have the parasympathetic nervous system, which is the calm nervous system. That's a nervous system that's supposed to be controlling your brain throughout the day. But if you sense something dangerous, the most primitive part of your brain, the sympathetic nervous system, takes over. And this is, you can't think yourself out of this. This is basic sensory information. If you smell a fire, what do you smell? Do you smell a fire or do you smell a rose? What do you hear? Is it somebody screaming or is it your favorite music? What do you taste? Is it something, is it poison or is it a hot cinnamon roll, right? So the primitive part of your brain relies entirely on sensory information. So if you were to open up your front door and see a saber-tooth tiger across the street, the sympathetic nervous system takes over. You can't stop it. Takes over. Raises your heart rate, it raises your blood pressure, it tightens your muscles, and it prepares you to fight or flee. But, you know, it's 2023. What do? We shut the door. We call the authorities. They come out. They tranquilize the tiger. They take it away. An hour later, it's gone. The threat is gone. And at that point in time, the parasympathetic nervous system is supposed to retake control of the brain. And what does it do? It lowers your heart rate. It lowers your blood pressure. It relaxes your muscles. But for patients with widespread pain, that's not happening. But the brain is stuck in a constant state of fight or flight. So the next question is really that they talked about in the conference is, what are the risk factors? Why did my brain do this? I don't know. Why did my brain go into fight or flight? And what the research found, now I didn't go to the conference, or I tried to go to the conference last year, even virtually, and I couldn't, and the recordings, couldn't get through the recording for one reason or another. But anyway, 2 years ago, what the research showed is that for 80% of the kids that this happened to, there was a history of a major physical trauma. Getting hit by a car, having a broken leg, broken arm. That 14 days of pain puts the brain into a constant state of fight or flight. You know, that's your brain going, uh-oh, you're in pain. We have to protect you, right? So again, for 80% of the kids that this happens to, there is a physical injury of some type. And I work with you guys all the time, virtually every day. And the injuries are so diverse. There's a lot of broken tailbones, a lot of falls, a lot of being hit by cars, broken legs, things like that. 14 days of pain puts the brain into a constant state of fight or flight. For the other 20%, it is a history of abuse or bullying. If you had, for example, and we know it takes 20 days of abuse or bullying in a child or an adult to put your brain in a constant state of fight or flight. If you're anxious, you're in fight or flight. So Laura says right here, I was hit by a car in high school. Exactly. You'd be amazed at the number of patients who were hit by cars. I was working with a patient who was run over by a car and her entire pelvis was crushed. It was one of those amazing It's amazing that she survived. But let's go back to the history of bullying or abuse. So, if you grew up with an alcoholic parent as a child, your safe place was school. But as soon as you walked home, your little child's body and brain started to protect you, because the closer you got home, you would then be checking, is mom or dad drinking? Because when mom and dad is drinking, they get violent, right? And that constant state of fight or flight every day through your entire childhood puts your brain into a constant state of fight or flight. Now, I'm exactly the opposite. My home was my safe place. I grew up with a kid who became a rapist murderer. And I was one of his earliest victims in 4th grade. And so I went into fight or flight as soon as I got up in the morning. Get woken up. Hey, hon, time to get up. Got to go to school. You better believe my brain locked down into fight or flight. And as I walked to school, I'm looking for him. The closer I got to school, the more scared I got, the more hypervigilant I got. And it was brutal. It was brutal. 4th grade through high school. I did not leave my house without fear from 4th grade through high school. God's honest truth. So this is not mental illness. They do not call this a mental illness at all. This is an injury to the central nervous system. It's as we call it, a central nervous system maladaptation, that basically the brain has been habituated into fight or flight through life circumstance. But there's a very, very happy ending here, because we know exactly how to turn it off. I can turn a fight or flight in every single one of you in 5 minutes if we do a specific exercise called I Spy. So what we have to do now is we have to reteach the brain that we're safe. There's no reason to be in fight or flight anymore. But you can't think yourself out of fight or flight. You have to prove to your brain you're safe. And the way you do that is with sensory information. You could talk about it forever with a therapist. It'll never go away. We have got to physically turn off the fight or flight response by telling the brain you are perfectly safe where you are. And so if anybody wants me to do that, just let me know. You can put it in the chat and I'll do it. I Spy. We do it all the time. I do it several times a day on the phone with people, and every single time they're shocked. And there's another piece of that puzzle too with the anxiety disorder. Laura wants to learn I Spy. Okay, let me go through a few more questions and then we'll do it. Okay, so hold on a sec. So Avery says, I was a very happy child. Then IC came out of nowhere in 5th grade. So Avery, what happened in 5th grade? Mary said, you had this disease before your anxiety. Well, what I would say to you, Avery, is you were hurt before you had the disease, that it was actually the injury that caused the nerve sensitization. This is not a disease anymore. We don't consider IC a disease in the vast majority of patients. And our new guidelines say there's no disease process happening in the vast majority of bladders out there. That for the rest of us, this is a neuromuscular disorder. Yes, some people do have a disease in their bladder, but the odds are you probably don't, because most patients don't. So the injury begins this process of the nervous system becoming very sensitive and the muscles becoming dysfunctional. Mary says, it's a diagnosis of endometriosis in my younger years, something that continues beyond the end of menses. Well, the advantage of getting older, especially going through menopause, is your estrogen levels drop, and the lower the estrogen level, the less active the endo. Vicky says, am I running live chats on both YouTube and Facebook? Yes, right now. If I'm looking here, I'm looking at Facebook. If I'm looking here, I'm looking at YouTube. Facebook is on AT&T. No, Facebook is on Comcast, no. Hold on. And YouTube is on AT&T. Brenda says, I had a hysterectomy when I was 20. I have fibromyalgia for years. I have high anxiety. I have IBS. I have multiple urine infections and IC. It's hard to tell me if I have a UT or an IC. Brenda, what you have is wickedly sensitive nerves, hon. You are a neuromuscular patient. The IBS is exquisitely sensitive nerves in the gut. The fibromyalgia, that's nerve sensitivity, the anxiety. You are IC subtype 5 central sensitization, just like me. Not your fault. You didn't do anything wrong, hon. You got hurt. Denise says, what's my take on D-mannose? D-mannose, if you have recurring E. coli infections, D-mannose is valid. If you don't, it's a waste of time. Sue says, lots of cognitive behavioral therapy on YouTube to help you. Exactly. The way we retrain the brain is with mind-body medicine techniques or cognitive behavioral therapy. You just have to be really, really clear. Nobody's saying this is mental illness at all. This is injury or trauma to the nervous system. And we have to now physically train the nervous system how to calm down and be normal again. And we do that with mind-body medicine technique. No shame, no blame at all. Sue says, I believe it's called dialectic behavioral therapy now. Works for me. And Kathy says, or Sharon says, try CBD. It's amazing for calming the mind and body. It is. Sharon says, I'm playing right now. I'm a natural redhead with blue eyes. Hello, sister. I'm pretty sure my mother had IC and my dad had pudendal neuralgia. I had both with chronic regional pain syndrome, trigeminal neuralgia, bilaterally, heart problems, osteoarthritis, migraine, Sjogren's, fused back. I had a severe injury, head injury, widespread pain. The chronic regional pain syndrome now makes the IC and TN worse. I feel like the pain has taken over my life. I can't function to get out of my house. I don't cook as much. My sleep is disrupted. I believe that things went downhill when I broke my back and had a head injury in 1995 at work. Yeah, definitely. That type of trauma would do it. The head pain was so bad I couldn't eat, talk, or couldn't stand my husband kissing me. My back was so bad I couldn't stand the vibration of them building a new Mormon tabernacle by our house. I lost weight. My childhood was quite normal, except that I went to college at the age of 13. Girl, you are smart. Did independent study at high school and then off to college. I was overwhelmed. After my husband passed, I was in a wreck. Then had my back fused, tore my rotator cuff, cervical spine. You've had 30 surgeries in the last 20 years. Okay. So Sharon, I'm giving you the biggest giant hug in the world. You have been through stuff. Just close your eyes, and I just want you to imagine everybody in here right now standing right next to you, putting our hands on yours and just sending you so much love and so much kindness and so much support. Honey, none of this was your fault. I don't want you carrying any shame or any blame for what's happened. Number one, yes, Christine, I'm the advocate for that. Okay, so concept number one is we have to start with being a redhead. We are redheads. That means we have a double recessive gene that changes the way our brain processes pain. Redheads have more nerves, 40% more nerves than non-redheads. That's why it's hard to put redheads out for anesthesia. We wake up earlier. It's harder to have dental work. We have got nerves coming up everywhere. So redheads are already known for being more sensitive. Not your fault, not my fault. And the odds are you've already been adapting your life based upon that. You probably don't use Glade plugins in your house or scented candles because you're probably way too sensitive for that. That's how a redhead is wired. Okay? And every tribe needs somebody who's sensitive because it's the people who are sensitive that can tell if it's good water or bad water or good food or bad food. Being sensitive is not a bad thing. Being sensitive is a blessing because we are the ones who are going to smell the fires first. I found so many gas leaks in my neighborhood, it's ridiculous. And so there is a blessing to being a redhead and being sensitive. But here's the challenge here. Is not only do we have sensitive nerves on the outside, we have sensitive nerves on the inside. So it's not surprising that your mom had a sensitive bladder because she was probably the redhead too. My mom had a sensitive bladder and she was a blonde. My sister, sensitive bladder, she has got brown hair, but it's in the lineage. We're Swedish and Norwegian. So that's your foundation. We can't change how you and I are wired. That's our foundation. The problem now, though, is that you sustained a major injury. And that's extremely traumatic, even in a non-redhead. But for a redhead, that's even more traumatic because we are wicked sensitive. What I would say to you, and the whole Sjogren's, yes, I have Sjogren's. The heart problem I get PVCs, although that's from sunken chest syndrome, I'm told. That was from my dad. I inherited that from my dad. Focusing on things, I'm going to sneeze, hold on. Oh my goodness gracious. See those flowers. The flowers got me. I think it would be fascinating for you to try palmitoyl-ethanolamide, because this is what has helped me the most in the last 50 years. When I take palmitoyl-ethanolamide, all the nerves calm down. And I'm normally really great. But that's why I hate mosquito season. Because all it takes is one mosquito bite and my nervous system amps itself right up again. And I have 4 or 5 mosquito bites right now from last night. So it would be very interesting to see if palmitoyl-ethanolamide calmed some of your nerves down. So that's concept number 1, is what can we do to calm these injured nerves down? And then concept number 2 here is that you have pain on bladder fill, but honey, you're now in estrogen atrophy. So that probably doesn't relate. I mean, that's something new that's going on. That as we get older, our skin gets drier. Your bladder is supposed to be wet on the inside. The wetness, we call it the mucus, the mucosal barrier. But once you're of a certain age and your estrogen levels drop, your mucosal barrier thins. Thus, your bladder becomes all the more vulnerable. And of course, you and I have already sensitive nerves down there. And so we want to make sure your skin is really healthy. So I don't know how old you are, but for genitourinary syndrome of menopause, when we have to keep our skin moist and healthy, and the way we do that normally is with topical estrogen. But I completely agree with you. Number 1, you're a redhead, and then you sustained a very, very traumatic injury, and it was a head injury. And a back injury. And that certainly would have created the foundation for a lot of this. But ultimately, in the end, we can't go back and we can't change the past. So what you've got to do is, number 1, is my skin healthy? Are my nerves healthy? Are my muscles healthy? Those are going to be the 3 most important things for you right now. Do I have estrogen atrophy? Are my nerves super sensitive, and are my muscles tight? And that's where you need to be focusing your time and attention. You don't have a bladder disease. You are a widespread pain central sensitization patient based upon your history. I mean, yeah, could you have a weird infection? Maybe, but they probably already ruled that out. The odds are this is all the result of the injury and trauma from when you broke your back and you had the head injury. Okay? And that cognitive behavioral therapy is so important here. Nobody's saying this is all in your head. This is just about training your nerves. Now, Sharon, here, let's see. Sue says, how many redheads don't have a single tag left on your clothing? You cut them off, right? Exactly. I have to tape my seams down. If, how they do the seams and the type of thread they use, holy moly. And Sharon, your mother's half Cherokee and your dad was Scottish. We have research that shows that the Cherokee Indian population actually is more vulnerable. So you've got the Scandinavian, Northern European sensitivity combined with the Cherokee sensitivity. The clotting disorder is not going to relate. Wow, you didn't walk for 7 years. Girl, you've been through it, hon. You've been through it. Not your fault. I don't want you carrying any shame or blame, but you've got to now buckle down here. Is my skin healthy? Are my nerves healthy? And are my muscles healthy? You might benefit from physical therapy. The odds are you probably had extremely tight muscles this entire time from that injury and from all the pain. I mean, have you had a pelvic floor assessment? Laura says, I'm blonde and I can't wear any tags or anything around my neck because your skin is so sensitive. Exactly. Exactly. Christine, so Christine asked about the next generation DNA urine test by Microgen. I'm a huge fan of them. Obviously, I've worked with the company for many years now. I myself have had 2 next generation tests and I found them absolutely fascinating. I don't get all emotional about, there's a lot of people who don't like next generation testing because they don't know how to interpret the data. So what did your data say, Christine? What were your results? What did they find in your urine? Sue says, and Rhonda says, oh goodness, I'm a quarter Cherokee. Yeah, they did that. The Cherokee Indian research, there's only one study. It was done in Oklahoma by a doctor whose name started with L, who's long retired. All right, Sue says, since having COVID, I've not been able to shop at the grocery store by myself. It's overstimulating. You become nauseous and dizzy. I have to get in and out. And you're waiting to get into a COVID clinic. So that's very common with long COVID, hon. You know, people at our last meeting, I was talking about this fantastic IC conference in New York and wanting to go. I've made my decision. I'm not going. And I'm not going, number one, financially, it's a bit of a strain right now because things are tight for everybody and they're tight for me. But more importantly, Heather, who works with me, just came back from Europe with COVID. And she brought in a different strain of COVID because she was in Scotland and England. And so she was COVID positive. She wanted to come to work and we were like, no, you can't come to work until you're COVID negative because you now have a completely different strain than what we've been exposed to. And we all got COVID a month ago, or not even 3 weeks ago at the hospital, 2 weeks ago on the 12th. And I simply do not want to expose myself to COVID again because long COVID is affecting 10 to 15% of everybody who's gotten COVID. Sue said, I had multiple TIAs and collapsed lungs. Girl, wow. Oh, I'm so sorry. Jennifer, to put it simply, and you can watch this chat all over again, it's now been linked to inflammatory bowel disease. And it was the eye researchers at Emory who were working with IC patients who had that retinal disease, who made the second correlation that Elmiron pentosan polysulfate appears to correlate also with inflammatory bowel disease. And we've known for many, many years now that some patients who take Elmiron get rectal bleeding. I mean, they found that in the first clinical trial before it's even approved. Diarrhea, colitis, things like that. The problem, though, is that it's a little bit worse than that, because there are kind of stages of bowel irritation over time. So you might have some minor irritation first, but in a worst case scenario, what happens is something that's called dysplasia. And that's when the cells actually change. And dysplasia is a tremendous risk factor for cancer. It's the dysplasia, the cells affected with dysplasia that are the most at risk of becoming cancer. And so this was research that was done at the Elmiron Institute. They were the ones who first made that correlation, and they just published the first major paper a couple of weeks ago. But we've had several papers, 4 or 5 papers since 2005, case reports of patients who developed rectal bleeding and things like that. And of course, when they stopped the medication, they healed. So I went over a case reports in 2005, 2015, 2022, and now the new research in 2023. So we want to make sure that we let anybody who's taking Elmiron know that if you're having bowel symptoms, diarrhea, et cetera, that this is going to be very important for you to talk with your doctor, because what the research shows very clearly is that when you stop the medication, the bowel symptoms go away. But there's a worst case scenario where the bowel becomes so incredibly dysfunctional and the dysplasia is widespread that they have to remove the entire bowel. And that's what we don't want you to go through. And I could say more, but I'm not going to say more right now. I think it's just, I'm going to hopefully do a survey or see if I can get one of the researchers to do a survey that we can send out to our membership so that you can, so that we can develop our own data, just like we did with the pigmentary maculopathy. We just have to be very aware that litigation is happening with the eye issue, and if more research comes out with the bowel issue, undoubtedly this could also now lead to some lawsuits respected to that. And so I need to be very, very careful about what I say. I'm looking at the next couple of years. Sharon said, doing a new assessment. What? With a different doctor, a urodynamic study. Just had 2 vascular surgeries on my left leg. It's numb and swollen. I also have Meniere's. Oh my goodness, I'm so dizzy. My ears ring too. And my mom had Meniere's. That's another reason why I don't really like flying very much. She said, it's been almost 3 years since first COVID, and then I got it again at New Year's. Yeah, exactly. I mean, I'm sorry. People are saying COVID's over. Seriously? No, it's not over. They're just not talking about it. My regular hospital had a COVID outbreak like 6 weeks ago among their staff. And again, we were at the hospital. I had never had COVID, but I spent hours and hours and hours at the hospital with my dad and my mom before they died. And I got COVID from being in the hospital. And I'm pissed off about it. I didn't want COVID, but I had to be there. I wasn't not going to be there. Mary said, my urogynecologist told me she wouldn't know what to do with the results of next-gen testing. What can I do? Well, we don't know. I mean, we don't know until you get it, because if it comes back with a fungus, that's a no-brainer. It's like, okay, you have a fungus. We're going to do an antifungal. So that's a cop-out. It's just data. It's just hard facts. Take the emotionality out of it. Let's just see what's in there, just out of curiosity. Erica says, I have something going awful on. My allergies are off and running. Pyridium helps, otherwise it feels like glass coming out of the urethra. My IC was bad before. I thought I was getting off easy. I finally had 10 out of 10 flare. I look pregnant. Doctor said, your analysis shows inflammation, but no infection. You're able to have sex, but you could feel the inflammation. Every gland on the left side is swollen. Okay, and you have long COVID too. So listen, hon, ICU does not cause swollen glands. Infections cause swollen glands. I get swollen glands on the left side of my crotch. I've had them a couple of times, and they're usually associated with cysts. You ever get and it's usually from friction, from dry skin. You ever get a big old pimple on your vulva, and it hurts like the dickens, and you're like, you dying to squeeze it and get rid of it, but it's not at the surface yet, and it takes a couple days to get to the surface, and then finally you see the white pus, and sometimes it pops on the own, and sometimes you take a needle and you pop it yourself, and it's very, very painful. I've gotten swollen glands there, but the fact that you got swollen glands on your left side, that tells me that something else is going on. COVID cystitis is possible. I think you would be an excellent candidate for a next generation DNA urine test. Let's see what's in there. I think you would be an excellent candidate for that, because for example, I mean, concept number one is you could have a fungal infection from taking antibiotics. Concept number two is you could have a rare drug-resistant infection. And or concept number three, the fact that your allergies are out of control in that Curtis-Nickel 9 subtyping, phenotyping system. There is a subtype called allergenic cystitis. And so what they would normally recommend for a patient who's flaring with allergies, even if you have allergies also, is an antihistamine. So are you taking any antihistamines like hydroxyzine? Sharon says, I cut my Elmiron dose in half. I feel like I need to get rid of it completely. It's just overwhelming to deal with so much, including the fact that I've had 2 open heart surgeries and LADs, pulmonary embolisms, blew out my first graft. I'm due for a colonoscopy. Doctor said my gut isn't working. Honey, you have got to take this research to your doctor. Number one, Elmiron is a blood thinner. You're not supposed to be taking Elmiron if you're having surgery. That's a well-known effect. So you've had pulmonary embolisms, and you've had so much going on, boy, and now your gut isn't working properly. Woo, Betty. If you have a colonoscopy and they do a biopsy and they find colitis and or dysplasia, I wouldn't take it, but I'm not your doctor. I can't give you medical advice. You know, it's very important that you stop chasing symptoms. You've done that for decades. Stop chasing your symptoms. It's time to focus on underlying causation. We have to focus on treating the underlying problem. Elmiron doesn't fix the bladder wall. It just coats it. We got supplements, bladder builder, bladder rest, things like that have a similar effect that do not come with the same risk as Elmiron. So for the estrogen atrophy, doing something with chondroitin could certainly give your bladder a little bit of extra oomph, a little bit of protection. But man, you had embolisms and you're on Elmiron? I'm shocked. I'm shocked. You need to have some really good discussions with your doctors here. I'm concerned about that. And I might be wrong. I might be full of crap. That's why you got to work with your doctor, but something doesn't feel right. Hold on. You know, it's going to be very tricky, honey. You have to work with your doctors very, very closely here. So you've had the embolisms, which are clots. Elmiron does have a thinning effect. And so my concern would be that the Elmiron might be helping you in ways that you don't understand, while it could be hurting you in other ways. I don't know. I'm just guessing. I don't know. I just don't know. But at least for your colonoscopy, it's going to be fascinating to see what they do. And guys, for anybody out there, understand that, there's a lot of concern about colonoscopies triggering flares. They rarely ever trigger a flare. The Miralax protocol, really easy on the bladder. Don't worry about the preps with your bladder. Just get it done. Let's get somebody to look in there and see what's going on. Renee just got diagnosed with bladder infection. I've been on Bactrim for 3 days now and still no relief. Renee, did they do an antibiotic sensitivity test, or did they just throw it at you and say, hey, we think you have an infection, you got a positive dipstick, here's some Bactrim, but they didn't culture it? Very important that they culture it to identify if it's drug resistant. That's one way of identifying if it's drug resistant. And call your doctor and say you're not any better. Bactrim just may not be the right antibiotic for that specific infection. Sue says, get vaccinated, please. Yes, exactly. Jennifer said, I'm having bowel issues now. I think I have, and I'm having colonoscopy in September. What else can I take to help? Good healthy fiber. Try to get your fiber intake up. Acacia fiber, Heather's tummy fiber is really ideal for people who are more sensitive because it doesn't provoke the nerves in the bowel like an insoluble fiber. So Heather's tummy fiber is this is the fiber that I use, Heather's tummy fiber. Use it every day. But I will tell you, I also eat beans. I eat a lot of beans. I'm not having any. I got to tell you something funny. I'll tell you something that's quite funny. My mother kept a diary of her bowel movements for years. Little notepads. I am finding a record of her bowel movements all over my house. And it's like, come on, she was like totally normal. I was like, Mom, why do you have a diary? You're normal. And she's like, oh, I just like to keep track. It's hysterical finding all these little notepads where she documented perfectly normal bowel movements. I didn't, but in the end, she couldn't remember the last year. She was having trouble remembering. So I knew it helped for the last year. Sue says, I would get swollen glands in my groin area when I was in a bad flare when I was younger, but never had infection. The doctor doesn't understand why. Erica said, I have a colonoscopy scheduled on June 19th with Go Lightly. No, Go Lightly should be fine. But you can ask if you can switch to the Miralax protocol. The Miralax protocol is basically 4 Dulcolax, you take it five in the afternoon if you're having your protocol the next morning. And then an hour later, you do half a bottle of Miralax in water or Gatorade or whatever you can drink. And then you do the other half after that, and it'll clean you out. Not too traumatic. I did it. Yeah, for the colonoscopy prep. Sharon said they gave her a 2-day. Yeah, it's normally a 2-day prep. I mean, the thing to remember about colonoscopies is about a week before, you got to cut way back on food that's hard to digest, like steak. Just slow everything down. Let's fill up that bowel with easy, soft things rather than hard, chunky, difficult to diagnose things, right? Yeah, honey, Jennifer, it's right here. You can get it in the IC Network store. Heather's Tummy Fiber. Love this stuff. Absolutely love Heather's Tummy Fiber. Here, I'm trying to drop it down. There you go. Sorry, I've got 2 cameras that I have to make happy here. Okay. Denise said, I had the prep with pills, a lot of water, and no flare. Actually felt more than normal. Good. Yeah, there are new preps now that are much easier. They're pill-based, where you don't have to swallow all that stuff. I need to get another. I should get another colonoscopy in the next couple of years myself. What Jennifer says, what else can I take for burning pain? Well, where is the burn, hun? Is the burn internal or external? Tell us where your burn is. Okay, so Sharon, where is it burning? Yeah, the doc said to eat soft foods before the prep. In fact, he wants me to get away from things that take days to digest. Yeah, I don't eat. Okay, your burn is in your vagina. It's horrible, son of honey. That's estrogen atrophy. That's probably estrogen atrophy. Are you using any topical estrogen? So concept number 1 is that's estrogen atrophy. Concept number 2, it can be pelvic floor spasms. But are you taking any estrogen, any topical estrogen? Erica says, thank you so much. I can swallow the pills, but I can't even drink barium without throwing up and the nausea. Yeah. Girl, you're not alone. You're not alone. They're getting better. They're getting better and better with it. They just have to make sure that your bowel is empty. And so that's why, I mean, and who is it? It was one doctor. Who was that doctor? It was somebody on the doctor show who did a colonoscopy, and he decided to ignore the doctor's instructions on food. And the night before he had it, he ate a normal meal, and they had to stop the colonoscopy, and they chewed him out. They chewed him out because his bowel was now filled with food and they could not get a good look. And they put him on the air and he apologized. He said, yes, that was me. I was a little arrogant. Sharon said, yes, you're using the estrogen cream, but I do forget. The estrogen cream is so important, hon, for your skin health. And what the research studies show is that topical estrogen is remarkably safe, carries a far lower risk of cancer than oral estrogen. So the topical estrogen really is the treatment of choice. And so let's make sure your skin is as healthy as it can possibly be. So get on a regular schedule with that estrogen cream. And I need to do that too. I'm a little bit passive aggressive with it myself. But then the other thing is what's going on with your muscles. So again, as I said, the trauma of my parents dying was awful. And I was really kind of curious in a weird way. It's like, okay, how is this going to affect me? Because what did I say? I said, what did I say about it? Oh, I should be a case study for how severe stress affects pelvic pain, because my stress was awful. I mean, watching my dad die and then watching my mom die, days apart. So what happened is I had a very severe flare where I was peeing every 5 minutes. I felt a lot of burning, especially at my vaginal introitus. My first guess was that I was just dry because I've been feeling a little bit more dry anyway. So I used my topical estrogen cream vaginally, and it didn't fix it. And an hour later, you know, man, I grabbed my wand and I went in there and my muscles were rock hard, and I stopped that flare in its tracks by using my wand and getting the muscles out. And so that was really, again, confirmation that the vast majority of flares that I had, where I was peeing every 5 minutes, was really not my bladder wall, it was my pelvic floor. And we have new research that supports that it's the pelvic floor that's actually driving the really insane levels of frequency urgency. It was crazy. Erica says, I miss you taking breaks to help then. I've been thinking about you. I know, right? I mean, it's about time. So my mom should have walked by a couple of times with her walker going to the bathroom. And then if she was in the bathroom and she had a bowel movement, she would have gone, Jill, I need you in the middle of a meeting. Like, okay, guys, hold on. Go get the glove, help her. And then my dad always, he was just hungry. He'd either bring the mail in or he would stand at the door going, it's dinner time, make something. And it's like, Dad, I made something. It's the oven. It's in the oven. You can just pull it out of the oven and eat it. It's a casserole. It's like, no, you need to do it. He was very, he was difficult. Yeah, Dad, I'm sorry. I know you're here right now. And I know you're saying you're sorry, but God damn it, you were ornery that last year. He was ornery. He wanted to drive and I wouldn't let him drive. And oh my God. Okay. Anyway, I just feel them. I feel them very, very close. My mom is with me when I walk because she loved to walk with me. And my dad is just, he's not hovering, but he's like making sure I'm being good to his house because it's his house. I'm going to laugh about it. Jennifer said, what doctor did you go to that helped you with this disorder? I've had this since I was a child and I can't even go pee through. You know, honey, a pelvic floor, the most important doctor I ever saw was actually not a doctor, it was a physical therapist. And having a proper pelvic floor physical therapist. Erica says, please continue to share stories of them. I will. My dad had some crazy stories. Crazy story. So, Jennifer, if you give me your zip code, here, I can do this on Facebook. YouTube, I'll just have to describe it. So what I'm going to do is I'm going to share my screen on Facebook, and I'm going to go to the database that you can look up, where you can look up a good doctor. I mean, a good physical therapist. So hold on a sec. You're gonna see my desktop. There you go. Look at that desktop. All right. And the website you go to is Pelvic Rehab, short for rehabilitation, pelvicrehab.com. This website is the bomb. So I'm just going to put in, let me put in Michigan. You can put your zip code in. Okay, and so this is the easiest and quickest way to find a proper pelvic floor physical therapist trained in this work. If you go to a physical therapist who tells you to do Kegels, they're not trained. If you go to a physical therapist who just wants to do biofeedback and they put a wand in your vagina or your rectum to teach you how to relax your muscles, they're not trained. The training is done by the Herman Wallace Institute. They're based in Washington. And it's hands-on physical therapy, a finger inside of your body that is the single most effective way of releasing these muscles. So on this database, you can see right now, there are physical therapists everywhere that are trained. This training is widespread now for physical therapists. The ones in yellow have the formal certification. They are certified in pelvic rehabilitation. The ones in gray are in the process of being certified, and some of them are certified. They just haven't updated their listing. So we just picked a random one, somebody in Grand Rapids. So now we have her name, right? She's got a master's in physical therapy, and it will then give us the details. It will tell us exactly where her clinic is with a phone number and usually a website link. So she has been faculty. Look at this. Faculty for the Herman Wallace Pelvic Rehabilitation Institute since 2009 and loves to inspire rehab professionals with her knowledge and experience. You want to talk an outstanding physical therapist. Laura, it's pelvicrehab.com. Pelvic and then rehab, short for rehabilitation, REHAB.com. Boy, did we pick the perfect person. If you're in the Grand Rapids area, I'm going to suggest Jennifer Vande Vegte. For God's sake, she's a faculty member of the course which certifies these physical therapists, and she's just northeast of Grand Rapids. So having a proper pelvic floor assessment. Now, when you go for a pelvic floor assessment, it's quite interesting. Here, let me get you off my desktop here real quick and give you my face. I'm back. So when you go and have a pelvic floor assessment, their job is to study your anatomy, study your body. And so they're going to start externally. They're going to have you walk up and down a hallway. Let's see how you walk. They're going to look for tension patterns in your legs and your lower back and your thighs. If you have a lot of low back pain, that's very, very important to them because they need to look there. They need to try to figure that out. There are muscles, psoas muscles that go along both sides of your spine that go right down and anchor into your pelvic cavity. I have a long history of tight tension in my psoas muscles on my left side. I will wear heating pads on them. They're going to measure your legs. You have one leg longer than the other. They're going to they're just studying your body. That's all we want. We want an extra set of eyes. Okay. If you're calling me, I can't talk right now. I'm doing a meeting. Okay. Well, then they're going to ask if they can do an internal examination. An internal examination is a finger inside your body touching muscles. It is the single most important part of the examination. Okay. Because if they can touch a muscle and trigger your pain, that is what I call your hallelujah moment. That's very, very exciting. And so so don't be afraid of that pelvic floor assessment, because if you have a hallelujah moment, that is like, oh my God, what are you touching? You found it. So that internal examination of finger inside your vagina, or for men inside of your rectum, is critical to help us understand what could be going on with you. Because for some of these muscles, that's the only way that you can touch these muscles, because these muscles are up inside on the inside of some of your hip bones, Okay. Now, what's going to make that appointment super successful is your ability to discuss your symptoms, because what you say to them gives them a roadmap. So you don't just say, I have pain down there. Please don't do that. You need to be much more specific. I have pain when I sit down that goes away when I stand up. I occasionally have pain that shoots down my leg. I have pins and needles. Um, uh, Anything that you can do to try to describe your symptoms will give them a roadmap. And especially if you always have pain in one spot. Donna, no, that's not right. Just end it with the B. It's pelvicrehab.com, not rehabilitation. Rehab. Okay. Here, let me just do that. Good try. Good try. That's it right there. Okay? Pelvicrehab.com. Okay. If they find you have tight muscles, this is spectacular. This is exactly what we want to know. Because as long as you have tight muscles, you're going to have poor blood supply, and that's going to affect your bladder and your vulva and your rectum, etc. If you've suffered with constipation for a long period of time, that could be from tight muscles. If you can't release urine, that could be from tight muscles. If you have pain with intimacy, that is from tight muscles. Okay? And here's what we knew. Pelvic floor physical therapy outperforms every other bladder therapy almost 2-to-1. And that was just confirmed in some brand new studies that were released during the AUA meeting. Pelvic floor rehabilitation works and works successfully, and I'm the perfect example of that. Now, it's not a one and done. You can't just go once and expect it to go away. If you've had symptoms for a long period of time, you're going to be in physical therapy for 3, maybe 6 months. And ideally, what they will do is they will teach you what to do at home. Ideally, they will give you the independence of how to use a wand like I do, so that if you're starting to flare with pelvic tension, you can nip that sucker in the bud. This is really vital. Learning independence is important. But there's something that you've got to be attentive to, and that is, as you're working with a physical therapist, your question is always going to be, are my muscles slowly getting better, or are they always locking back down into tension? Because if they always go back down into tension, then that tells us that there's something putting stress on that muscle, and that's usually bones. So as an example, if you have a bad hip, if you limp, if you have a bad knee, for me, a bad SI joint, my SI joint moves. Or if you have one leg longer than the other. If you have one leg longer than the other, your hip is tilted. It might be like that, but it's tilted. And when you're a kid, your body's resilient. But once you're in your 30s, 40s, 50s, your body's not as resilient, and that gentle trauma from the slight angle could cause long-term pelvic floor tension. Or if you have an ankle that rolls in, or an ankle that rolls out, or if you got Morton's toe, or you got a history of shin splints, plantar fasciitis, all of that's going to affect how you walk, which is absolutely going to be redirected back up into your pelvic cavity and could cause long-term pelvic floor tension. So if your muscles always lock back down into tension, then you want them to look beyond the muscles and have them take a step back and go, gosh, what do you think would be putting tension on that muscle? Can you help us try to understand that? Now, here's the other issue. Some pelvic floor physical therapy isn't covered by insurance, or it's just too expensive, right? And if you can't afford it, and I understand that, Renee, we will look that up. Hold on. If you can go just once, that would be incredible. Because ideally, what I want you to do is I want you to walk out with the name of the muscle that's tight. So for me, it was my levator ani muscles, which are the shallowest muscles. Let me get my model, which you guys asked for here. Hold on. See, I just got the impression that my dad was smiling at me. It's funny how those things happen. I think that they're close. Okay. So Jennifer says, mine always tightens back up. So we have to figure out why it's tightening back up. And that, again, that points us to bones. Jennifer said, should you ask your pain management doctor? Ask your pain management doctor for a referral to a physical therapist, for sure. Let's get somebody else looking at your body, because you don't just want to treat the pain. You want to figure out what's causing the pain so you can fix what's causing the pain so that you don't have pain, right? So let us, as John asked, let me introduce you to your pelvis, right? So it's a 3-sided box, right? It's a box that's open right up here at the front. So here's the front, here's your pubic bone. You've got these triangular bones right here. And you notice the left side and the right side mirror each other, and they come together and they attach here at the pubic symphysis. Right, there it is. Now, let's look at the back. So here's the back. Here's your vertebrae from your spinal cord. Here's your sacrum. Here's your hip bone. The SI joint is right here where the sacrum attaches to the hip bone. So here we have the sacrum. And then we have the oh so mighty tailbone. And I want you to look at everything that attaches to the tailbone. Look at this. The tailbone is the center. It's the structural center of the pelvic floor. And if you look at the tailbone, it curves under, right? But if you have a broken tailbone and you've got a tailbone that is angled out at the right or poking out instead of curving under, do you see the chaos that's going to cause? That's going to cause terrible chaos to your pelvic floor over time. So I've shared the story of the IC patient I featured in our magazine who attended one of these meetings. She'd been bedbound for years. And I went over the subtypes, and she was having positional symptoms. She had pain when she sat down that got better when she stand up, which are the symptoms of pudendal neuralgia, which means you have muscles so tight they're squeezing nerves, right? So she goes to her urologist and goes, I think I have pudendal neuralgia. And her urologist said, I agree. I think you have pudendal neuralgia. See you later, Laura. You're very, very welcome. And if you like these meetings, come on over to the IC Network and become a member, okay? That'd be great. Okay, so let's get back to this patient. Every IC treatment failed, kind of like Sue when we were talking about Sue earlier. Very similar patient. She goes to her doctor, says, I think I have pudendal neuralgia. Muscles so tight they're squeezing nerve. Doctor agreed. So she then went to like a orthopedic surgeon. And they did, the next doctor did x-rays and visualization. And here's what they found. Her tailbone was poking out and was at an angle. It was massively out of position. Now, it took her a year working with physical therapists and a chiropractor. And I have issues with chiropractors. I don't like chiropractic care. I think it's pretty harsh. But anyway, what she did is she worked with a physical therapist and a chiropractor off and on throughout an entire year. And at the end of that year, they had her tailbone back in the correct position. And you know what happened? She was virtually healed. The last time I talked to her, her symptoms were 95% better. She was still having little issues every now and then where she'd have to go back to physical therapy. All that time she did bladder treatments, none of them would have worked for her. Her problem was a structural problem. So if you have long-term pelvic floor tension, we got to start looking at structures. We got to start looking at structures. And so many of you have tailbone injuries like me. And it's like, are you sure you have any trauma? No, can't think of any. And then, half an hour later, oh my God, yes, I remember it happened. That's happened more than a few times. No, nothing happened. Then you really think about it. Oh yeah, man. Yeah, I remember that. I definitely had a problem. And okay, so Jennifer, I have bilateral sciatica and disc disease and osteoarthritis. Okay, so if you have sciatica, you have tight muscles. Sciatica is caused by tight muscles squeezing nerves. Okay, Sharon says, I have pain when I sit down. You have pudendal neuralgia. Pelvic floor therapy had me order several things for home use. My plantar fasciitis is connected to my pelvic floor. Makes sense. This is the first year my insurance is covering everything without copays. So, Sharon, did you do physical therapy? And what did they find when you did physical therapy? And Sharon, there's a very important book for you to get. Girl, you need this book. Breaking Through Chronic Pelvic Pain. This is the Bible for patients with injuries like you. And it will really help you understand your anatomy more. This book taught me more than any other book I've read in 30 years. This is a fantastic book for anybody with a history of pelvic injury, pelvic trauma, tight pelvic floor muscles. The first, the first 3 or 4 chapters teach you what's there. It's kind of important that you know what's there, where the muscles are located, et cetera, where the nerves are located. And then the 2/3 of the book is how they treated pelvic pain and the different types of pain and why they happen. Like, for example, let me give you a good picture here. This is a healthy nerve right here, right? This is a completely healthy nerve. It's round. And what is that? And the thing about the nerves that you might not know is that nerves need good blood supply. So every nerve has its own little micro blood vessels. And the way the nerve works is it releases substances into a calcium. I think it's calcium from the nerve into the blood vessel as the nerve transmission happens, and then it pulls the calcium again right out of the blood vessel. So healthy nerves are round basically, and they've got really good blood supply. But when you fall and you land on your butt, this is what happens. You get a crush injury. You get a crush injury to nerves. And what does that do? You don't just have a physical injury to the nerve. You have a physical injury. You have a compressed nerve. The nerve fibers are trapped within the compressed nerve sheaths. The compression damages cells in the nerve sheaths. There's this whole ripple effect that happens when you fall badly. And we know blood vessels are broken because you get a bruise, right? He also talks about trigger points. So when the way that I learn when I read is I have to color. It's just I do. So I colored the important muscles and the important trigger point. And that's because I have trigger points right there myself, which is why I colored it. So Sharon, this book is in the IC Network shop. It's $29.99. It's $7 cheaper than Amazon. I promise you that it will help you. I promise you. And if it doesn't, I will buy it back from you. This is, in my opinion, the single most important book for somebody like you to get with your level of injury. And it will help you understand why the plantar fasciitis matters and the feet matter. The chapter on the feet's mind-blowing. Sue says, what do they do with broken tailbones? Mine has 3 fractures, but they don't really say anything about surgery. Yeah, I mean, that's the tricky part because I have a broken tailbone too. The tip of my tailbone actually broke off and was floating for years. It's not floating anymore. Excuse me while I touch my tailbone. Now my tailbone has like a knob at the end of it. It's like it's round. It's like a round stub. It's just a question that you might have to ask a physiatrist, or an orthopedic surgeon, because if your tailbone's out of position, that's going to influence everything. Sharon says, I have a tailbone injury that happened in 7th grade. That's when mine happened. I have sciatica too. Yep. Feel like my back isn't going to hold me up. Well, we got to strengthen those muscles, girl. I mean, and Jennifer said, I hurt my tailbone years ago as well. Yeah, definitely ask about pelvic floor physical therapy. And the thing is listen, I mean, the more you move, the better it gets. It's very important that we get up and walk. Laying in bed, sitting for long periods of time is only going to weaken everything. When you move, when you exercise, your body produces natural painkillers. You get the blood flowing, and that's only going to help your muscles in the long run. But that gets hard when you're in pain. It's just so important to try to, even if it's just walking up and down the hallway in your house 10 times, 5 times the first day, 6 times the next day, 7 times the next day. You got to slowly but steadily try to build up that functionality there. Sue says, it's very frustrating when you have multiple overlapping problems like plantar fasciitis, tailbone fracture, scar tissue, neuralgia, plus a torn hip after hysterectomy, even to know where to start. But Sue, the important thing here for you and for so many patients out there is, number one, not your fault. You've done absolutely nothing wrong. You were physically hurt. And the challenge too also is that there's a legacy to those injuries. The legacy to those injuries is nerve sensitization, muscle tension, et cetera, et cetera. And so in the end, we can't change the past. We can't change the future. We have to focus on today. And anything that you can do today to help your muscles relax, keep your stress level down, calm nerves down, that's the secret to success. Is having that routine every day that will just center you while you're waiting for surgery or anything else. Let's try to move. Let's try to, if you're struggling with anxiety, to use some positivity in there, to use some mind-body medicine, keep everything calm and chilled, because we know that if you're stressed and you're anxious, your pain is going to intensify. We got to calm everything down. So I just like breaking it down into workable systems. It's like, okay, I'm going to eat right. Like last night, when I went to the store, I bought sliced sourdough bread. And I made myself a grilled ham and cheese sandwich with sliced sourdough bread. And I knew while I was making it, it was stupid. I knew I would wake up this morning with a big fat belly, because that's what happens when I eat white bread. And I mean, and it's slowly going away because that's just me eating gluten that I shouldn't have eaten. And I have thrown it away. I've thrown a whole loaf away. I had 2 pieces because I'm not going to do that. And I knew when I bought it, I shouldn't have bought it. I'm trying to be very assertive and aggressive now on how I treat my body, how I treat my spirit, and making really good decisions. So it's just simple. Getting up, eating the right food, trying to move, doing your muscle work, and doing your mental health work, the mind-body medicine, and doing anything that you can do to put your body, spirit, and soul in a better place, right? While we're waiting. Jennifer says, looks like it's a fantastic book. I think it is the book of books. Sharon says, I've been through 5 physical therapy ladies. The last one sent me home with tools. It's time to try again. And you had 2 large babies. So the 2 large babies are huge. That definitely messed up your pelvic floor. Kim wants to see the book again. Here it is, Breaking Through Chronic Pelvic Pain. I'll give you the link. Here, hold on. I'll get the link and I'll put it in. I'll put it in Facebook. Hold on. I mean, I think our book, IC 101, is damn good. It's really, really good for helping you understand subtyping. But for anybody with a history of injury or trauma, you can't go wrong with Breaking Through Chronic Pelvic Pain. I love it. Here, I'll give you the link. Oops. There you go. Renee says, you look good. I understand about this food. You know, I hate carrying extra weight. I just hate it. I don't feel good. And I just don't like being all bloated and stuff. That's just my choice. Donna says you got several Urodoctors on Amazon. My nurse practitioner called in a prescription for heparin lidocaine, and my insurance will cover it. Aww. Denise says you look so thin. You lost weight. I did. I have lost about 10 pounds in the last 6 months, and I want to lose another 6 or 7 pounds if I can get down to 138. I'm probably 144, 142 right now. I'd love to be like 135. I know if I get below 135, I don't look good. I look like a skeleton. 135 is my magic weight. But I have saved my favorite clothes all the way through high school. Like I can wear my high school sundresses, and I will this summer. That's when they made good clothes that lasted a long time. These really cute short cotton sundresses. How tall am I? I'm 5'9". Cassidy said the only medication that gives me some relief is ketorolac, which I take it's needed. Other medications haven't helped at all. Cystoscopy showed inflammation. What do you think would be an optimum treatment option for inflammation? So, number one, it's always nice to try to figure out what's causing the inflammation. And so, generally, when I mean, there are a couple of different ways that we can go. You know, concept number one is chemical injury. The bladder, like any other part of the body, can be injured, and generally it's injured through some sort of chemical exposure. So if you've had chemotherapy for cancer, that's well known for triggering the bladder and causing a lot of bladder irritation. If you're drinking a lot of diet soda, a lot of Coke, taking a lot of multivitamins, things like that, or using ketamine, those all are certainly going to play a role in injuring the bladder wall and causing inflammation. You got to remember, your bladder was designed tens of thousands of years ago. It was never designed for today's massive acid load of coffee and stuff, unless maybe your ancestry is around the equator. For me, I'm Northern Swedish and Norwegian. My ancestors were not exposed to high levels of acid, so I don't have the defenses for that with evolutionary adaptation. So anyway, we explore the concept, number one, of chemical injury. The second thing, Cassidy, that we want to explore is that the health of your bladder, the bladder wall in general, especially the mucus. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, because urine is body waste. Urine contains ammonia and urea and all sorts of irritants. So how can the bladder hold ammonia for hours at a time and not get damaged? Well, it's because your bladder is like your mouth. It's a hollow organ that's wet on the inside. There's a really thick coating of mucus in the bladder. We call it the mighty mucus. And the purpose of that mucus is to act as a barrier. It protects the skin. This nice thick coating of mucus, irritants in your urine are not going to reach the fragile cells of your bladder wall. And it's going to be much harder for bacteria to get to the bladder wall, because the bacteria have to dig through the mucus first, right? Unfortunately, this mucus is estrogen dependent. So when you're young and have lots and lots of estrogen, you have lots and lots of mucus, and you can get away with stuff. But if you're on birth control, if you've had hysterectomy, total hysterectomy, if you're taking Lupron for endometriosis, or if you're just getting older, late 30s, 40s, 50s, 60s, you are now in estrogen atrophy. It is happening. It happens to every woman. And as the estrogen levels drop, the mucosal barrier thins. And the bladder loses its ability to defend itself. That's not a disease. That's just estrogen atrophy. We call it the genitourinary syndrome of menopause. And so If your vulva's dry and your vagina's dry, so is your urethra and so is your bladder. So we got to work on the skin health. And the way we do that is with topical estrogen. That is the treatment of choice for genitourinary syndrome of menopause. Now, the third question comes to mind is there another inflammatory, an autoimmune situation happening in your body? I mean, if you have Sjogren's, if you've got lupus, if you have Lyme disease, Borrelia actually has been found in the bladder wall. If you had COVID, COVID cystitis is common. The patients who have no history of bladder issues, they get COVID and they come out of COVID with severe bladder issues. They get diagnosed with interstitial cystitis, but it's not interstitial cystitis, it's COVID cystitis. And we've actually found the COVID virus living in the bladder and living in the penis. The COVID virus is brutal. It's elusive. It's going to take us decades to understand everything that the COVID virus does. And so it depends upon what we think is going on there. And so we have to figure out kind of your subtype before we can talk about treatments. Understand too that if you have tight pelvic floor muscles, you are in a state of ischemia. That's going to cause your bladder wall to break down. So we got to try to improve blood supply and get the pelvic floor muscles normal. So, you need to be phenotyped. If you want to call me during the week, I'd be happy to talk with you and see if I can help figure out what your phenotype is. And that will then help us focus on the most logical treatments for your unique case. Sharon says, I live in house arrested since my last heart surgery, but I have several sizes of clothes packed and tucked. Yeah, I hear you. Sue says, compounded lidocaine is not that expensive. My insurance doesn't cover it either in a big. Yeah, they're just kind of cutting everything out just to reduce expenses. Donna says, do you think any insurance might cover it? Yeah, some insurance does cover heparin lidocaine. Kaiser does. Sharon says, what should I ask my urogynecologist if I can use the estrogen cream daily until it gets better? Should I ask? And then go back to 2 to 3 times per week? Sure. That's very normal for patients who are really, really dry. Normally, they will have used it every day for a couple of weeks and then switch down to 2 to 3 times a week. I would ask them, sure, see what they have to say. All right, guys. Well, listen, we have been at it for 4 hours today. Erica says, I'm still trying to learn my phenotype. I'm going to call you Wednesday after a couple of, sure, call me up. If you get so I'm on a first come, first served basis, kind of, sort of. And so you can call the 800 number, go to the patient education line. And if you don't get me, just leave a message and I'll call you when I can. Okay. And I also call back at night sometimes because I'm on the West Coast. So if you're on the East Coast, I'm still working at 4:30 my time, which is 7:30 your time. So I might call you even up to 8 o'clock. Mary Jo says, during my internals with my pelvic floor physical therapist, I had so many hot spots on the left side of my vaginal wall. And honey, that's very common, especially if you're right-handed. I was exactly the same way. And what the physical therapist said is, I was a big tennis player. Oh, thank you, Donna. So think about tennis for a moment, right? So I'm right-handed. So to play tennis correctly, I'm going to step on my left foot. I have all my weight on my left hip. And then as I swing, I'm rotating my weight and rotating this hip and rotating my SI joint. And SI dysfunction is the racket sport injury. So my SI issue came from playing tennis. Donna, Kaiser is on the West Coast. It's not on the East Coast. And you spelled it correctly. It's an HMO. So Mary Jo, now they know where to work. They have to work on your left side. That's exactly what they did for me. So you guys, when you leave a message, just do me a favor and you can tell me if I can call late or not. Okay, that would be good. Okay, I'm going to end this meeting with I Spy because my voice is starting to give out, and I'm going to start coughing soon. You can hear my voice is slowly failing here. Okay, so we talked earlier about how do we get the brain out of fight or flight? How do we calm these nerves down to calm all of the pain levels down throughout your body? And as I said when I was talking about it, the language of fight or flight is sensory information. You can't think yourself out of fight or flight. You have to demonstrate to your brain you're safe. If we demonstrate to your brain you're safe, we can turn it off. Sue, these are my shoes. I wear Hoka's every day, and I'm so much better. My feet are so much better. And I don't have plantar fasciitis or anything anymore. Okay. So I Spy is a fantastic way of turning off fight or flight, calming your central nervous system down. So let's go ahead and do it. We're going to do two things. We're going to do I Spy, and then we're going to do another technique for anxiety. Okay, so let's just go ahead, if you don't mind, let's just go ahead and take 2 deep breaths. Let's just go in and out. And let's do it again. In and out. Okay. I want you to pick something in your room, or if you're looking at a window like I am, pick something that you like to look at. Is it a tree? Is it a bird? Is it a dog? Is it a painting? Just pick something that you like to look at. I've got a beautiful redwood tree right outside this window, so I'm going to look at that. Squirrels live in it. So I want you to pick something that you love to look at it. Let's just look at it for a couple of seconds. Wind is blowing. It's a nice, beautiful day outside. Okay, let's do a deep breath in and a deep breath out. Okay. Besides my voice, can you hear anything? Do you hear a TV on in another room? Do you hear the wind? Do you hear a furnace? Do you hear a fan? Do you hear somebody talking? Just take a moment and listen. We're just engaging the sense of listening, hearing. Deep breath in. Deep breath out. Okay. Can you smell anything right now? Are there any scents in the room? Can you smell anything? I have some Vicks Vapor Rub, which is my go-to during allergy season. So just try to use your sensory information, see if you can smell anything. It can be bad too. If somebody just was in the bathroom and left something stinky, that's okay. We're doing smell. Okay, deep breath in. Deep breath out. Okay, are there any flavors in your mouth? Now we're going for the sense of taste. Can you taste anything? And it's okay if you can't. But can you taste anything right now? Like what do I taste? I taste something. I'm not sure what it is. It's kind of bitter. A little bit bitter. It's not bad. Okay, so just what can you taste? Think about it. Okay, deep breath in. Deep breath out. Last but not least, I want you to take your hand and I want you to rub it up and down your leg. All we're doing is we're engaging touch receptors up in your brain. There's no threat. I'm wearing soft jeans. Just rub your hand back and forth a couple of times. You are making your brain work. What's so cool about the brain is that it looks like a thunderstorm. Different parts of the brain light up depending upon what you're doing. And it's really quite beautiful. Just like flying over a thunderstorm in an airliner. It's gorgeous. Okay. Deep breath in. Deep breath out. Okay, now comes the fun part. Erica, we're not done. We haven't begun the fun part. Okay. If you could look at anything that would put an immediate smile on your face, what would that be? Would it be the ocean? Would it be an eagle flying? Would it be a family member? I want you to close your eyes and I want you to visualize something that a waterfall, something that you would just love to look at. And I'm going to visualize the ocean, sun setting, warm, gorgeous day, right? Okay. Just close your eyes and think about whatever it is that you would just love to look at right now. Okay, deep breath in, deep breath out. Okay, what could you listen to that would put an immediate smile on your face? Would it be your favorite music? I listen to a lot of Kenny Loggins, but I also listen to a lot of BPS because I'm young at heart and I like K-pop. Would it be laughter? Would it be ocean waves? I want you to close your eyes and I want you to think about what would you just love to listen to that would put you immediately in a great mood. What's your favorite music? Go through a few bars. Okay, deep breath in, deep breath out. What could you smell that would put an immediate smile on your face? For me, every single time, easy, 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 bacon cinnamon rolls or bacon apple pie. Hot cinnamon rolls is my go-to when I am under stress. So what's your favorite smell? Is it roses? My cat, I love the way my cat smelled. Close your eyes and I want you to visualize your favorite smell. And for me, it's this ginormous cinnamon roll that I'm heating up in my oven right now. Okay? And the smell is divine. Okay? Deep breath in. Deep breath out. Okay, what could you taste that would put an immediate smile on your face? I don't care if it's icy friendly or not. What is your favorite thing in the world to eat or drink? What is it? Is it chocolate? Is it lasagna? Is it wine? What is it? Close your eyes. And for me, I'm sorry, hot cinnamon roll every single time. That's my go-to. I want you to close your eyes and visualize that you have your favorite food or drink in front of you. And you are taking that first bite and you have closed your eyes and you're having an orgasmic moment. Oh my God, it is so good. Right? Deep breath in. Deep breath out. And last but not least, what could you touch? What could you touch that would put an immediate smile on your face? Would it be warm sand? Would it be fresh, clean cotton sheets the first time you get in at night to sleep on them? Oh, come on. What's better than clean cotton sheets? That first night is divine. The pillowcase smells so good. Or would it be your lover? I was working with somebody last week or the week before who just flat out said, my husband. That's who I like to touch, right? It's your favorite thing to touch. It would make you immediately happy. I want you to close your eyes. Is it a cat sitting in your lap and you're petting him? Is it a dog sitting right next to you? Close your eyes and visualize it. I'm going to go with the cat. Okay. Deep breath in and a deep breath out. Okay, how do you feel? You got a smile on your face? You got a smile on your face? I don't know about you, but I feel mellow. I feel mellow when I do that. So what we've done is we have physically turned off fight or flight. We have flooded our brain and our nervous system with good sensory information. Works every time. It'll stay off for hours. It is, Donna says, so good. Right, Donna? I mean, like, it's amazing how good it is. Okay, but there's a second piece to this puzzle. So let's go back to our whole fundamental concept here that this is trauma-driven. Physical trauma or emotional trauma. And because your brain has been habituated into fight or flight, the remnant of that is anxiety disorder. I've asked a lot of doctors. Yeah, I mean, you're the no person. Hey, Jill, you want to get on a plane and go to New York for an IC conference? No. You want to go out to dinner? No. You want to go take a drive? No. We're the no people. And I've asked my doctor, I've asked several doctors, including a lot of experts, why does my brain go negative? I'm a very optimistic person. I think you can see that. But why did, past tense, did my brain always go negative? And the answer was, it's the chemistry of fight or flight. It's just your brain trying to protect you. Your brain just thinks your life is at stake, so it's going to try to protect you. So, the challenge with that is that then every time you have a negative thought, you break yourself right back into fight or flight. You know, and so here we've got all the good vibes going, and then bam, negative thought, damn it, right back into fight or flight. So, and it's not just one negative thought a day. For somebody with anxiety disorder, as I had 100 negative thoughts a day. Every other thought was a negative thought when I was at my worst in my 20s, by far, and even my 30s. I used to have panic attacks going to the doctor. I hated going to the doctor because I felt like they were hurting me all the time. Because back then I was doing bladder installations and dilations. Yeah, they were hurting me. So even with a master's degree in psychology, I just couldn't figure it out. And so I signed up for a class in anxiety management at my local hospital, and it was life-changing. I have not had a single panic attack since I've taken this class. Even going through all the trauma with my parents a couple of weeks ago, not a single panic attack. And so the class was developed by an orthopedic surgeon with anxiety disorder. And it was fascinating because the first thing that resonated with me was, like, I always thought that I was a walking billboard on being messed up. I thought all somebody had to do was look at me and know that I was just a messed up person. And when I walked into the class, the first thing that happened is I realized that, and we all introduced ourselves, I realized that we were all normal people who just had something happen to us. And so, for example, the people who won the first lottery in the state of California were in my class because they developed anxiety disorder after winning the lottery, right? And so that took a lot of shame away. It's like, oh my God, it's not me. I just got hurt, right? That was really important for me to absorb. And the instructor said, listen, we're not here to psychoanalyze you. We are not going to go into your childhood. We're not going to do any of that. Man, if you want to talk to somebody about that, I will set that up for you. But that's not the purpose of the class. The purpose of the class is we're going to get you out of fight or flight. And I'm like, great. I don't really want to talk about what happened to me as a kid. I talk about it a lot now, but I didn't back then. Okay. So he said, just as you can be sensitive to chemicals on the outside, you're very sensitive to chemicals on the inside. And right now you are overdosing on adrenaline. Adrenaline is the chemical mediator of fight or flight. Every time you have a negative thought, you give yourself a jolt of adrenaline. You don't just have one jolt of adrenaline, you got 100 jolts of adrenaline circulating through your body. And it's this massive chemical overload of adrenaline that is perpetuating so much of this anxiety. It's just constantly keeping you worked up. So he said, what we're going to do is we're going to get you out of adrenaline overload. And it's really easy to do. Oxygen turns off adrenaline. So you're stuck in the negative thoughts, and negative thoughts are raising the adrenaline. So what we're going to do is we're going to break that cycle. So whenever you have a negative thought, the first thing I want you to do is I want you to visualize a stop sign. Just close your eyes and fill your brain up with a giant stop sign. Just stop. And the thing is we all do that anyway, but it's just like, you got to be really consistent. You have a negative thought. Hey, I'll get COVID if I'm going to fly to New York. Okay, that's a good negative thought. Stop. Stop it. And then take a single deep breath in and a single deep breath out. I mean, in and out. Now that single deep breath chemically neutralizes the adrenaline from that negative thought. It's done. It's over. It will never haunt you again. So stop sign, deep breath. And then the third step is you have to remind yourself it's a thought. It has no freaking power. So what I say to myself is, oh my God, Jill, you're not God. You can't predict the future. For all you know, tomorrow's going to be the best day of your life. You're just guarding. Your brain is just guarding. Okay, so stop sign, deep breath, minimize the thought. Stop sign, deep breath, minimize thought. He said, okay, that's a system. The next week, I want you to be really attentive to your negative thoughts, and I want you to do it. And I'm like, all right, I like the chemistry. I like the chemistry. It's fascinating. I'm in. I'll give it a shot. And of course, I had my first negative thought going out of the room. It'll never work. What a stupid idea. But I did it. Stop sign, deep breath, minimize the thought. And I was shocked. I was shocked by the number of negative thoughts I was having. I kind of tuned it out. And I was shocked at how mean I was to me. Most of those negative thoughts were about me. Oh, you're pathetic. You know, you're an embarrassment. Those were the thoughts that were going through my brain. And that first day, I did stop sign, deep breath, minimize the thought at least 100 times, maybe double that. The second day, I did it about 50 times. Third day, I did it about 20 times. 5 days later, I only had to do it once. And for the first time since fourth freaking grade, when I got attacked, I wasn't afraid. I was calm. It was mind-blowing to me that I broke the cycle of negative thought, adrenaline. And I will tell you, now, I think you can see by looking at my background, I am very deliberate in how I live my life. I live in a happy home. This home is filled with things that make me smile and inspire me. Like this love, you know, I've got love, I've got believe, you name, I've got that stuff all over my house. The drapes are open, the sun is shining in, I do not live in a cave. I'm very deliberate with how I live my life. And I got to the point where I only had to do that maybe once every 2 or 3 months. My negative thoughts stopped completely. Once I got the adrenaline under control, bam, done. I was good. It's amazing. Diagnosed with early uterine cancer. I was doing it in the car on the way to the hospital. Didn't have a panic attack before my hysterectomy. I was doing it, driving to see my father as he was dying. I was doing it. Well, I'll tell you, then the firestorms hit, and then COVID hit, and all of a sudden I was back to having negative thoughts. The anxiety is real. There's no doubt about it. We're living in very stressful times. But you know what? I knew what to do about it. I always kept it under control. Always. Negative thought, stop sign, deep breath, minimize the thought. Sometimes I'd let one go. I've had 2 in a row every single time. Only once if I had 3 negative thoughts in a row. And I double down, I do it twice. Stop sign, deep breath, minimize thought. I never let my brain go down the negative pathway. And that's one reason why I am so much better. Why my physical health is so much better. because I don't have IC symptoms anymore. I don't have IBS anymore. I don't have vulvodynia anymore. I don't have migraines. Now, what I do have is very sensitive nerves and a tweaky muscle, and that's fine. I can deal with that. And now I'm back to doing it, once every 2 or 3 weeks. I'll do stop sign deep breath. It's a system that works. So I double dog dare you to try it. I want you to do I Spy every day, and I want you to spend a week. Just be attentive to those negative thoughts. Stop sign deep breath, minimize the thought. I double dog dare you to try it because it completely changed my life. Now, my rationale, am I letting anxiety prevent me from going to New York? No, I'm making a very educated, informed decision about long COVID. I am choosing not to risk that because the odds are very high. If you're on a plane, you're going to get it again. But I'm not letting anxiety stop me. I'm making a good decision for me because I need to have my mental capacity here so that I can work for the next 10 years so I will actually have a retirement. So anyway, it is what it is. So do we have any other questions? Last call for questions. Last call for questions. Otherwise, I promise I'm doing it. It will help get you off your anxiety meds. Yes, I really hope so. You just gotta really nip those negative thoughts in the bud. It's your brain's just guarding you. That's all. It just thinks your life is at stake. But you're older now. What happened to you as a kid will never happen to you again. You're safe. But now we have to retrain it and show it you're safe. And we have to be very deliberate about that to calm that central nervous system down, right? All right, my friends. Well, hopefully I will be able to talk to several of you this week. And I'm looking forward to it. I wish it well. And again, if you found this meeting helpful, please come on over to the IC Network and become a member. Get our magazine, the IC Optimist, or you can make a donation if you want. I never go back and check, but yeah, Erica, yours happened in your sleep. Well, but you can use this in your sleep. But if you can, come on down over to the IC Network and support us too, okay? Because times are a little rough even for us. So we can frankly use the business. Don't buy something from Amazon. Come on over to our website. Okay. I will talk to you later. I wish you well. You can get the IC 101 book. We have all the top supplements for IC. Come on over and check it out. icnetwork.org. All right, guys. I think it was a really good meeting today. I feel good. Okay. I'm going to say goodbye to Amazon because almost everybody's left. Bye, Donna.